anyone do audio visual anymore? Audio visual. Who does AV? Thanks. These are zoom-in windows, so. Sorry. And my stuff is on the desktop. Thanks for doing this. Yeah, I don't have any. Stay with them for a sec. I mean, is that coming out? Here it comes. Let's see.
What's up?
What's up? Place that. Windows. It's a big files in there. Is there a plug here?
Yes. Right. It's up.
Okay, let's see. Okay, put this in just in case. I got it, thanks.
It's on me right now.
All right, got it. Okay. Oops. I could do it from here, I guess. This first one. Thank you. Why don't we get started? So we have two kind of long lectures and then one very short lecture at the end to prepare us for Monday. So we will finish on time. I'm sorry I'm late. It's just these elevators at Columbia, you know. Great things are happening here. They should put some sheets out the window so I can jump out and get downstairs faster, tie them together like this, like my tie, actually. Well, we'll just leave that for a minute. Look, I couldn't find any bungee cords, so I had a tie, you know. Let's see, what is it? It's a Giorgio Armani. Okay, the hell with it. Okay, anyway. Okay, so welcome to obviously the most important organ in the body. And it's a little bit of a paradox because, you know, something's the only organ you can completely replace. And it's not that patients don't need it, but on the other hand, it can be replaced. And so we're going to discuss that in brief. And here are my disclosures. This thing is being loud over here. And so we have to start with something very, very simple. So tell me, you dissect a body. Hello. Hello. Hi, everyone. It's like, where have you all been all this time? You mean med school, dental school? Okay. Waste of time. So anyway, you come across this organ. How do you decide what an organ does? Tell me how you...
A primitive way would just be to remove it from another animal and see what they can or cannot do.
Remove it from another animal and just see the residual of what they can and cannot do. So that's an excellent question. These days, we could do that genetically. It's called a knockout. You could do it surgically. You could remove a kidney or kidneys and see what happens, right? And therefore, you would have to conclude, it's a little bit counterintuitive, but you would have to say to yourself, conclude that whatever happens to that animal, as you said, is the opposite of what the kidney does. Okay, that's how knockouts work. It's a little bit counterintuitive, and it's not as linear as you may think. What's another way to tell what an organ does? You find this organ, your name is Gallon or something, the year is 400. Find some organ, you say, what is this organ? What does it do? What's another way to tell what an organ does? Did you say? Okay, so when we look at the kidney and see it microscopically, we have these balls of glomeruli, of filters. So it sounds like it filters something. Excellent. So a little bit, but that's sort of past Leeuwenhoek. That's up to the 1600s. These are intellectual revolutions to be able to look at something and say, I see this. That actually requires an event up here to be able to see. So what's another way to do it? I agree with the two statements. Anything else? Suppose an artery goes into the organ and a vein comes out of the organ. What can you do with that idea, with that hint? What could you measure? What? You can measure the flow. So you have a high flow rate into the organ, and now things go in and things come out. So what could you measure? What would you like to say? Does that help you determine what an organ does? Measure something that's different, the contents of the fluid. So if ammonia is very high going in, urea is very high going in, and it's low coming out, you can assume that the organ is an excretory organ for urea or for ammonia. You see how it works? And so these are the things that help us decide what an organ does in general, and specifically the kidney. So this is our outline and objectives for today. And basically what we're going to ask the question is we're going to take a bird's eye view of kidney function, and we're going to call that kidney versus the world, because that's what the kidney does. It fights the entire world. And it does so with this remarkably simple equation. Intake, that means what you guys are currently doing right now, minus your non-renal output, which I assume is what you guys are not doing right now. That means sweating, it means stool, it means vomiting. I don't see anyone vomiting yet. You will by the end of the lecture. And then it subtracts renal output. And this number, the attempt of the kidney is to force this number towards zero. Now, there's always a mistake made by everyone at the outset. So if you lose a lot to your environment because you have a diarrheal disease, no, the kidney cannot generate sodium atoms de novo. It is not a nuclear reactor. It is not the middle of the sun. However, what it attempts to do is reduce its output to try to force this equation to zero. And so we'll focus on that for quite a long time. And then, once we get finished with those 10, 15 minutes of discussion, you will have known everything you need to know in nephrology. That's it. It's over at that point. The rest are simply mechanistic details. and then we'll have to wade our way through it. But the beginning is what's really important. So let's start our query on these things. My computer would advance, it'd be a good idea. Which is not. We have a technical issue here. It's not advancing. Page 10. Nothing we can do. Oh, thank you so much. You're a genius. Okay, good. Thank you. Yeah. Yeah, the faculty are stupid. You're right. You were right. You were right. The first molecular. Yeah, the faculty is stupid. Okay, so let's start with the idea of a knockout. So what does a knockout do? Someone said, let's look at an animal, but it turns out that humans have knockouts, and what you can see in this line right here is the number of patients on dialysis, meaning that they have no renal function. A complete knockout of the kidney is called end-stage renal disease or end-stage kidney disease, ESRD or ESKD. And that means that they have no renal function, or they don't have renal function adequate to survive. So you can see 500,000 people on dialysis about in 2010. What about patients with a partial knockout? We call that chronic kidney disease. And that's when you have a progressive disease of the kidney that leaves you with less than 100% function. And you can see there's a marker in the blood called creatinine that increases. Let's use the number 1.5 as our cutoff for normal, and I'll explain that in a little bit. But you can see that, that there's tens of millions of people who have elevated creatinine and are walking around every day. And the best way to think about that is they have a partial knockout of the kidney. So we can use these patients to say, what do they look like? And therefore, we can try to understand what the kidney does as a result. So the first thing that happens in a patient with a partial or complete knockout, and those are somewhat linear ideas, because the more knockout you have, the worse these effects are going to be. So there is a dose response with the illness called chronic kidney disease. End-stage renal disease hits a plateau of badness, essentially. There's no function left. But as you go through this process of losing kidney function, you may get sodium overload. Now, this is particular, especially to the current modern diets, because our diets are filled with sodium. And in our current diet, the chance of sodium overload, if you have chronic kidney disease, is quite high and quite frequent. So what does a patient with sodium overload look like? They have lower extremity edema, or they can have edema if they're lying in bed, if they're bedbound. You check around, the buttocks will have edema. Lying in bed can give facial edema. Certain diseases are more likely to have facial edema, which you can see here. And edema is essentially water plus salt at this given concentration. So it's about, let's say, 140 millimoles of sodium chloride per liter of water. This is a very important ratio of sodium to water. I'll discuss in detail in a few minutes. But this ratio is maintained in edema fluid. We call it isotonic fluid, and it accumulates in patients with complete or partial kidney knockouts, so sodium overload. There's also water overload. That means that we're adding water. You see, I diagrammed that by a big L here. There's more water than expected for the appropriate normal ratio of these two substances, salt to water. And so the liters of water increases in the body, and that obviously is reflected in a decrease in concentration of sodium. No, there's no loss of sodium here. There's a gain of water. So there's a water overload that makes a patient what we call hypoosmotic, in other words, less than the osms that are appropriate. This causes neuronal dysfunction, somnolence, and coma, and if severe enough, will cause the death of the patient. There's also potassium overload, and you'll recognize the peak T waves here. And this is a further higher degree of potassium overload. You'll notice that the QRS is widened. And eventually this turns into a sine wave, and the patient cannot be recovered. So potassium overload is common in chronic kidney disease and in end-stage renal disease, in a large part because of the food we eat. We eat high-potassium diets. So a patient, we all gouge ourselves with salt and water and potassium, and a patient with a complete knockout or partial knockout is subject to an overload state, whereas normal people are not. There's also an acid overload, or a bicarbonate deficiency. You will learn that these are conjugate of each other, and therefore represent the same process. So in a normal patient, your pH of your blood is 7.4. Your bicarbonate level in circulation is 24. These are numbers that we all know. In a knockout, you may see a pH of 7.2. Doesn't sound like a big change, but that's reflected in the loss of bicarbonate. You notice that the bicarbonate was 24 to begin, it's now 16, and that means there's an 8 millimolar or milliequivalent deficit of bicarbonate per liter of body volume. Now, if bicarbonate is distributed in all of our water space, it isn't, and this is a sort of a fake number I'm making up, because the deficit that you see in the blood represents the tip of the iceberg of the deficit, because there are compartments that contain bicarbonate that don't have immediate access to the body water. In other words, your bone essentially is a store for bicarbonate. But let's just go with the numbers as they are. And if you see an 8 millimolar deficit per liter, and your body water is 60% of your body weight, let's say 42 liters of water, that means you have 336 millimoles that are missing from these patients. They physically are missing 336 millimoles. That's a minimal number of bicarbonate. So I weighed out 336 millimoles of bicarbonate this morning, and that's what's missing from a patient's body. It's physically missing. This salt is no longer in the body, and you have to ask the question as to where it goes. So does everyone know where bicarbonate goes when it's missing? Where did it escape to? The air. What does it turn into? CO2. Fantastic. And so that's just water over there, just to get it going. And listen, Jimmy Kimmel couldn't do any better than this, I'm telling you. They need to have me on their show. This will not cause weight loss, so I'm sorry I can't be on the Oz show. However, so what I'm now going to do, although it may cause weight loss, who knows? You vomit all night long, so obviously it was weight. So look at here. So this is 336 milliosms, millimoles. Sorry, you know, it's bicarbonate. Okay, so I weighed out protons. This is 336 milliequivalents of protons. So the two of them together should produce 100% CO2. Now, experiments never work, okay, because there's something wrong, there's something somewhere. So, you know, but, you know, you are going to see some reaction, right? Yeah, so, you know. So, I'll clean it up, don't worry. Okay, so, you know, this is what happens. So as you add acid to your blood, meat eaters, who are the carnivores in the room? Raise your hand. Oh, early death for all of you. Who's the vegetarians in this room? Okay, we have 3 survivors. I think one person in the back put up 2 hands, so that doesn't count. That doesn't count back there. But for the meat eaters, you're adding acid to your body, to your blood all the time. It binds to bicarbonate, and the bicarbonate is fizzed off. Who remakes bicarbonate? It's the kidney. So if you have chronic kidney disease or a knockout, you don't remake it to the same rate, okay? And as a result, what happens is that you have a bicarbonate deficiency or an acid overload. These are equivalent. Number 5, the part of the kidney known as the proximal tubule has 1-alpha hydroxylase, and it receives 25 vitamin D from the liver, which has received vitamin D from the skin. From skin to liver, you get 25 hydroxylated. Then liver into kidney, you get 125 hydroxylated. We call this triol. There's going to be 3 hydroxy groups eventually. No vitamin D in patients with kidney knockouts or chronic kidney disease. They can't hydroxylate it, and that's the active enzyme. Therefore, the calcium phosphate ratio will change. There will be higher phosphate levels and lower calcium levels, and as a result of this mishmash of this ratio, high phosphate, low calcium, there will be deposits of calcium phosphate. It's called calcinosis. And as calcium levels fall, neuronal activity will decrease, and patients who are severely affected with this will have myoclonus. Everyone know what myoclonus is? No? No? Myoclonus? Can anyone act out myoclonus? Christoph. Dr. Christoph. This is a nephrologist. Stand up, Christoph. Stand up. Stand up. Show me myoclonus. No, Christoph. That's like breakdancing. That's not myoclonus. Every time we have to watch him whenever he sees patients. Anyone else want to? Myoclonus is a twitch like this. Sorry, it's not this. You're not saying dancing. You know, it's like this. And what you do is you let your patient's arms sort of hang out nice and calm, and you'll see kind of a twitching motion. And if you see that, they probably have too low calcium levels, or else other things that are involved in kidney function are abnormal, which I'll talk about in a minute. So this myoclonus activity, it can be very subtle. Some patients, when you sit them at the edge of the bed, will have truncal myoclonus, which is very scary, right? The entire trunk will move. Christoph, stand up and try it again. Oh, come on, Christoph, stand up and try it again. Let's see you. All right, he's refusing now. He's smart. Okay, anyway. The kidney makes erythropoietin. It's under the influence of HIF. It's under the influence of hypoxia and iron deficiency. If you don't have a kidney, you don't make EPO. If you don't make EPO, you don't rescue, remember, the red blood cells after they express GATA2. Remember this, there's a certain point in their development that they need EPO, which is an anti-apoptotic factor. And so you will get anemic because the cell lineages in the bone marrow will stop and the cells will die. And EPO comes from a number of sources, but the kidney is the dominant one. And finally, the kidney makes glucose. Gluconeogenesis is one of its products. It makes glucose for the body. When you're starving, the kidney will turn on gluconeogenesis. It also, metabolizes insulin. The kidney is one of the major garbage cans for proteins. And they take up, small molecules go into the kidney, I'll explain in a few minutes, and then they're degraded. And for your diabetics, you'll have to lower their insulin dose as a result. You see that? If you don't have kidney function, you have to lower the insulin dose. They'll more likely get hypoglycemic because of these two reasons. Number 6, uremia. So there's other junk in the blood besides for sodium and potassium. I haven't opened my wallet since college. What will I find in here? Okay, here it is. Okay. And essentially, there's an accumulation of substances which are toxic. One of the toxicities that are seen are in the various linings of the body. One is the pericardium and one is the pleural space. And these can be inflamed and accumulate fluid. You see the heart is right in here. You can see the shadow of the heart right in here. The rest of this is pericardial fluid. This is called pericarditis, and it's typical of the very last stages of not having kidney function. Because the kidney actually has to clear whatever the toxins are that make it. And you get a rub, right? You get a rub. It's called sandpaper rub. And so I'm a literal-minded person. I went out and bought a piece of sandpaper. So, it's called the sandpaper rub. It's very scratchy. And we do hear this. And when you hear this, the patient absolutely, positively needs to be on a dialysis machine immediately. Because the accumulation of that fluid obviously can cause tamponade physiology, but even worse, you can bleed into the pericardial space. It's also a dysfunctional platelets. And when you hear this, and a patient has advanced renal disease, it's time for dialysis. The end stage of this is myoclonus, as I said, drowsiness. You can do various cognitive things. People get drowsy confusion, it's what it's called in uremia. We sometimes tell patients who have advanced cancer, and if they also have advanced renal dysfunction, and discussions of dialysis occur all the time in these patients. And we will all take our own stand as physicians and deliver the message that we are comfortable with, but some physicians say, this drowsy confusion is sort of, well, quote, it's not a bad way to die, unquote. So at the end of no renal function, rather than going on a dialysis machine, this is what you'll have, and there are a myriad of troubling conversations that will take place at that stage. Now, it doesn't have to be that way, because there's something called a dialysis machine, And in fact, guess what? There's a multi-billion-dollar industry to treat your patients. And they will come to you. You don't need to go to them. And they will find you. And the idea is dialysis. In fact, you can be dialyzed tomorrow in Afghanistan if you want by going to this website and plugging it in. You can take cruise ships, and you can get your dialysis on the cruise. It's probably not as great as this picture shows, but on the other hand, you will have life. You will have life by virtue of dialysis. You go to your dialysis center, you get plugged in. There's a massive blood flow. The heart needs to support this extracorporeal circuit, goes through a filter, comes back. There is fluid working in a countercurrent. You'll learn all about it. The key point is that without dialysis, you have a 6-day mean survival. That's a little bit too I don't know about those data. If I had to say from anecdote, my experience, I would say maybe 2 weeks or so. And so dialysis is necessary. It takes place for 4 hours. And the patient gets up, goes home, goes about their business, and they're living. That's the key thing. They're living. So what does the kidney do? Well, our end-stage patients demonstrate sodium overload, which is reflected in high blood pressure and edema. Therefore, the kidney must regulate your sodium content. Water overload, causing you a low osmolarity. Therefore, the kidney must regulate water content. Potassium overload, cardiac arrhythmias. Therefore, the kidney must regulate your potassium content. H+ overload or low bicarbonate, those are the same ideas. That's acidosis. Therefore, the kidney must regulate the content of acid by resynthesizing the bicarbonate that was fizzed to the atmosphere over there. Endocrine abnormalities, anemia, calcium phosphate ratio abnormal, too much insulin, and hypoglycemia. Therefore, the kidney must synthesize EPO, vitamin D, and glucose, and degrade insulin. And finally, the end stage of all of this is a so-called uremic syndrome, which is serositis, pleuritis, pericarditis, neuronal abnormalities such as drowsiness, drowsy confusion. And it regulates, therefore, it throws away various neurotoxins, many of which are just being discovered even now. This recent publication on a small phenol group that is said to be quite toxic that builds up in end-stage renal disease. So that's what the kidney does. It does 6 things, 6 categories of things. Okay. The other idea that one has to get from a bird's eye point of view, the global concepts before any mechanisms, is the idea of this equation. Because in essence, what this equation is telling you is that it's very sensitive to environmental perturbations and therefore can regulate itself accordingly. And we have to talk about that, not in detail, but from a global point of view first. It's a very important concept. Without that concept, you can't understand the rest of the mechanisms. So let's really look at this equation. I know it's very simple, but it's deceptively simple, and so let's go through it. Your intake is obviously your diet and intravenous fluids. Your non-renal output is this stuff right here. Tends to be, quote-unquote, less regulated. I mean, I don't know if that's true. I think sweat is probably highly regulated, cholinergic stimuli, and so on. But the renal output is the most regulated substance, and that produces the urine, which is the renal output. The reason for doing this is the kidney tries to maintain your steady state. That means the question is how much change will be in your body's constituents from day to day. It tries to make them 0. It doesn't do it successful. It's not an immediate response organ, but over a period of days, it will match whatever the environment is doing. How many days? There's different mechanisms that are timed differently. By 4 days, you're back into steady state, no matter what the environment throws at it. So immediate, and then over a period of 4 days, fine-tuning. Well, what does it do? Well, it regulates your weight. That's sodium. It regulates your blood pressure. That's sodium. It regulates your osmolarity. That's the amount of water. It regulates your acid base. That's bicarbonate, and your potassium. All the things I just said. It has to do this day by day to control that renal output. Now, as I said, all of that, I think, makes sense, and you can understand it from personal experiences. So let's look at some personal experience. What happens to renal output if our diet increases or decreases? So if our diet increases, your renal output obviously increases. If your diet increases, your renal output obviously increases, right? Because it's attempting to maintain steady state. Yeah? If your renal output if your intake decreases, in other words, you go for a few days, you're not eating, not drinking very much, your renal output will do what? Will decrease, right? Makes sense. Very straightforward. Everyone agree? Yeah. Number two, what happens to the renal output if non-renal output increases? Let's say you have a diarrheal disease. You have cholera. Liters of fluid being lost. Terrible stuff. What happens to your renal output? Decreases. Everyone good with it? So it's responding to other organs' availability. And lastly, the hardest question of the three is what happens if there's no renal output, if you have end-stage kidney disease? Then what? No output, end-stage renal disease. Then what happens? How do you get this equation to work? You can't, but we do medically get this equation to work by doing what? What's that? Okay, dialysis eventually, but prior to the need for dialysis during the partial knockout, the chronic kidney disease, what do we do? Absolutely decrease intake. The most important person in the medical team that works with patients with chronic kidney disease is the renal nutritionist. Do you get it? So if you have no kidney function, you're dependent on non-renal output to balance your diet. Think about that for a second. But we do use those mechanisms, both for a decreased intake. Guess what? What about diarrheal loss? Do we ever use diarrhea to balance the intake? What would you say? Doesn't sound like a doctor would want to make diarrhea to, not the doctor make diarrhea, to make the patient make diarrhea as a result to try to balance this. What do you think? Do we ever do that? Yes, we do. And why do we cause diarrhea in patients sometimes? To get rid of, there's something we need to get rid of real fast. And diarrhea is a great way to do that. It's potassium. So we actually can induce diarrhea, change the non-renal output. If you have no renal output, we have to work with the non-renal output as we decrease intake. So if you look at this simple equation, you can derive a lot of medicine from just this simple equation. And a lot of medical practice just comes from this three sentences, this three variable equation. Well, okay, what about the renal output? No machine can do everything, right? It has a limit. A pump can only pump water so high. That's the equivalent to making a voltage. A voltage can only be so high from a battery. A machine can only generate, transfer energy to a certain extent. What about the kidney? So in the red area is the maximal function of the kidney, the renal output. 20 liters in 24 hours is a ballpark number. 20 liters of water. On the other hand, it's unlikely that most of you are going to be drinking 20 liters of water. We'll discuss that in a second. More likely, there are periods of life, especially in other populations, not in ours, but in other populations, will be a lack of food or water. And so the kidney can put out very little urine at the same time, down to 500 mils. Classically, if you read textbooks, 500 mils is the limit. These days, I see textbooks talking about 400 mils is the limit. So let's use the number 4 or 500. Both are okay. That's the lowest amount of fluid produced by the kidney, quote unquote, within its normal range. If you have less than 400 mils a day, you have renal disease. But the normal physiologic range is anywhere from 20 liters to 400.4 liters. Sodium, 1,000 milliequivalents a day, that's a lot of bags of potato chips right there, and all the way down to 2 or 3 milliequivalents a day of sodium. It can conserve, it could have a urine that's almost free of any sodium. And conversely, it can have a urine that is completely filled with sodium. It can have a urine that's very concentrated, that means little water, or it can have a urine that is filled with water, and that means a large volume of dilute urine. And look at where our normal diet sits in this panel. Most of our diets sit right in here. So we're right in the good part, we're in the middle of the range, no problem with our diets. Let me ask you a question. You just joined a fraternity. And for some crazy reason, the hazing part of the fraternity is to drink too much water. You ever hear about that? Yeah, you hear about that? How about your colleges? They drink too much water? I went to Dartmouth. We didn't have fraternities there. So, what happens if you drink more than 20 liters of water a day? What happens to your osmolarity? Declines. What happens to your brain? It swells. Because it has osms in it that are now going to make water going to move into the brain. Have there been deaths in fraternities because of water overload? It's ridiculous. It's absurd. Beginning your life and you kill yourself by drinking too much soda, some beer or something stupid. Okay, well, it happens. Read this thing. Parents charged for allegedly making their daughter drink enough soda to kill her. It's pathetic, right? I mean, what are you going to say about this? A Tennessee couple accused of forcing the man's 5-year-old daughter to drink more than 2 liters. It was actually, read the second paragraph, 2.4 liters over 1 to 2 hours as punishment. So her brain swelled and she died. The family was charged with murder. They got, I think, a 30-year sentence. So 2.4 liters in 1 hour is 24 liters a day. I have to make a comment on this because I don't want any of you going home and swelling your brains. And the comment is that this is over 24 hours, number one. Number two, it's in the presence of a high solute load. That's a very complicated idea that we'll explain to you later in the course, okay? But this is a theoretical curve over 24 hours in an adult with a large solute load. This is obviously a kid who doesn't have the same, the shape of that curve would be the same, but it would be obviously fill a smaller area. So the kidney is incredible, from 20 liters down to 0.4 liters, from 2 milliequivalents to 1,000 milliequivalents, but there are cases of exceeding that. And you can imagine in kidney disease, this huge, beautiful red thing contracts and contracts and contracts, and that defines renal disease, where the capacities to excrete a lot or excrete very little are reduced to a central area. Does everyone understand that concept? You have a loss of flexibility at either side to throw away or to conserve. That's the definition of chronic kidney disease, right there. That red area would be smaller and smaller and smaller to the point where it doesn't exist, and therefore you have to radically change intake or non-renal output. So that's the kidney versus the world, and that's the idea that the kidney will remain in balance by putting out a lot or putting out a little. And let's not tempt it by trying to exceed Herculean amounts of fluid or salt. So we call this steady state, where the kidney tries to reach its goal. And the question now for the rest of the lectures is, what's the mechanism? You can imagine it has to sense things, and then it has to respond to what it's sensing from the environment. And the apparatus to do that is amazingly complex. Let's start by just looking at the big picture again for the mechanisms. It starts at the glomerulus. The filter of the kidney, the glomeruli, filters across itself approximately 20% of 1,000 liters of plasma delivered to it every 24 hours. So it takes 20% of your cardiac output, which contains 1,000 liters of plasma, and it filters 200 liters of it, 1/5, 20%. And that occurs in this filter system called the glomerulus. So the glomerulus is a filter that allows for water and ions and low molecular weight proteins to pass into the urinary space of Bowman, but doesn't allow cells or other substances or large molecular weight proteins to enter. Since 60% of our body weight is water, about 42 liters, that means Bowman space, to get the 200 liters into Bowman space, that means 4 to 5 times our total body water is in Bowman space every day. If we have 2 million glomeruli, that means each glomeruli filters 0.1 mils a day. And if we believe in these numbers of 200 liters a day, if your plasma has 140 milliequivalents per liter of has 140 milliequivalents per liter of sodium and 24 milliequivalents per liter of bicarbonate, what you can see here is that if you multiply by the 200 liters, it's 28,000 milliequivalents of sodium and 4,800 milliequivalents of bicarbonate that are filtered every day. So 28,000 milliequivalents of sodium from the 200 liters will enter into Bowman's space. This is a 1 kilogram jar of sodium chloride. So it's 1.5 of these. Will enter into your glomerulus every day, and 200 liters of fluid. I don't know if you've ever seen 200 liters of fluid. That's why I bring these things, because it's one thing for someone to say 200 liters. It's another thing to see how much that is. So it's 10 of these big guys right here. And so all of this fluid, my Giorgio Armani tie is not included in that, but all of this fluid is filtered in your glomerulus every day, along with 1.7 kilograms of sodium chloride. That's how it's going to maintain you in balance with your environment. Sounds a little overdone, doesn't it? 200 liters, all this. How much do you pee a day? How much do you pee a day? No, you don't pee 0 a day. You'd be one of our patients if you peed 0 a day. Are we going to skip this guy? Anyone else? How much do you pee a day? What's the volume of your pee? Unbelievable. 2 liters a day. It's not a good number, right? It's between 1 and 2 liters. So if you filter 200 liters a day and you pee 1 liter a day or 2 liters a day, you're reabsorbing 199 or 198 liters a day. So the kidney filters that. I'm serious. The kidney is a small organ. Look what it's filtering. Look at all the sodium chloride here. And how much sodium do you lose? Down to a few milliequivalents. You know, the average diet is about 3.5 grams of salt. That's about right here. And so that's all that comes out after filtering kilograms of it. So the question arises is why is this organ so stupid to have filtered the entirety of your body and hence to reabsorb it? And that's what it does. 98% of it is reabsorbed. However, this is the key paragraph. What is not reabsorbed is the 0.5 liter to 2 liters of excess water that you drank, containing the excess salt that you drank, the excess potassium that you drank, very little bicarbonate gets out, the urea and the ammonia. The final urine from that 200 liters contains exactly what you need to throw away. And that's how it maintains steady state. Its ratio, its gear ratio, is pretty pathetic. If you had to think of an excretory organ, you would think it would grab the excess stuff from the blood, gather it up and throw it away. What the kidney does is the opposite. It takes your whole body and then returns all of it, but for the part that is in excess. This presents a problem when we see patients. So here's the renal output, and and here's the renal output, and this presents a problem when we see patients. And the problem is, when we see patients, is that, in essence, they complain to us. Let's look at this problem very carefully. If you normally filter 200 liters a day of your plasma, and you reabsorb 198 liters a day, you leave 2 liters of urine, yeah? But let's say you only have 10% of renal function. You only filter 20 liters a day. Let's say you reabsorb 18 of those. You pee 2 liters a day. Doctor, I have nothing wrong with my kidneys. I pee 2 liters a day. I've always peed 2 liters a day. Why are you telling me I'm in renal failure? It's a very complicated issue because you can see this 2 liters a day is extracted from 200 liters. It's the extract, the distillate. But this 2 liters is only extracted from 20 liters. In short, there's 180 liters of blood that were not cleared of those substances that would have been cleared by the normal kidney. 180 liters were not cleaned in the second line here. And how do we know that? We just look at the blood, and you see the accumulation of all these substances in it that would have been cleared. This is very confusing for patients. It's also confusing for physicians, too. But the renal output is not a straightforward matter. It's here. Here's the full equation. Glomerular filtration minus tubular reabsorption plus tubular secretion equals renal output. You can see that it's a complicated number. And it derives from these three ideas, but these three ideas are linked and interdigitating, and therefore they're complexly associated with one another. So when your patient says, no way, no how do I have renal disease, because I have urine, they're right. But on the other hand, that's a distillate from a small filtrate, not a big filtrate. The complexity of this equation means we have to measure each one separately. And we need ways to do that. And that's what the rest of your nephrology course is, how to measure these separate ideas and how to integrate them in a clinical scenario. So we are going to take a 2-minute break, just 2 minutes. Just get up and stretch. And I'll begin again in 2 minutes, okay? Okay, let's get our seats, please. All righty. Let's grab our seats. How's the AV been? Been good? The echo is working and all that? Okay, good. Okay. So, the kidney versus the world. It will change its output depending on what we throw at it. And the question is, well, how does it do that? And why is it so smart to be able to recognize so many substances? The answer is, it doesn't recognize the substances as you may have thought. It filters your whole body into Bowman space and then recognizes self. It recognizes itself, reaccumulates the salt, water, potassium that is appropriate, moves back into the blood, leaves the excess behind. So 200 liters of filtered, and even superheroes like Dr. Garavi don't pee 200 liters a day, as far as I know. So 198 will be reaccumulated, and thousands of milliliter equivalents of sodium. And the way that this works is by huge filtration and then huge recovery of the filtrate in the tubules. We take a brief tour. The blood arrives, and the things that we need to know on this image is that the blood arrives through an afferent artery, forms a capillary plexus, and leads through an efferent artery. The reason we call these arteries arterioles is because that they have the ability to contract by smooth muscle, which is critical to the function of the glomerulus. They then form peritubular capillaries. What's magnificent about this image, and it's not obvious on first looking at it, but what's beautiful here is that the artery that enters, the afferent arteriole that enters, the efferent arteriole that leaves, that then surrounds through these capillaries, these peritubular capillaries, or these vasa recta, is exactly the same guy that entered in the first place. Isn't that something? This is paired. The blood that arrives and the blood that leaves and then surrounds this tubule is one unit. So what happens in that glomerulus is then reflected in the vasculature. And the regulation of kidney function for reabsorption is a combination of the epithelia of the nephron, the long tubule, and the surrounding vasculature. It comes from the same place. It's not a mysterious thing that this vasculature is regulating the blood that was just filtered at this glomerulus. And there are two shapes of these. One is a peritubular capillary, and the long one's the vasa recta. Here's our glomerulus, which you saw yesterday. It's a capillary loop. It happens to have a number of cell types around it. There's an open space called Bowman space. There is an epithelial tubule that it plugs into here. And this epithelial tubule has these squamous cells, and then these cuboidal cells and columnar cells. This is the proximal tubule. This is called Bowman's capsule. These are called visceral cells. These are called parietal cells. Those are old names. You can think of these, call these podocytes, and the cells of Bowman's capsule. And we have to deliver 200 liters of filtrate out into the space every day. So we need to talk about the measurement of filtration, the mechanism of filtration, and the regulation of filtration. Well, it's a little dry, but here we go. Ready? You're going to love it. No one can stick a micropipette into the glomeruli of patients in the emergency room. But if you could, you would measure the milliliters of filtrate per minute or liters per day entering Bowman's space. That would be the glomerular filtration rate. Simple, right? Stick one glomerulus, get the mils per minute, nanoliters per minute, whatever it is, and calculate up to 1 million nephrons, multiplied by 24 hours, you got the glomerular filtration rate. Functionally, we can't do that. Surprise. So we need a surrogate marker. And the surrogate marker is a molecule that is filtered through the glomerulus as readily as water, but may not be reabsorbed by the tubule or secreted by the tubule. Hence, its amount is unchanged passing into the urine. In other words, its rate of appearance in the urine is equal to its rate of appearance in Bowman's capsule. Enter into Bowman's capsule, appear in the urine at exactly the same amount and same rate. Therefore, if I just look at the urine, I know what's happening in Bowman's capsule. Do you understand that? If it were reabsorbed along the way back into the blood, this number would not be useful as a reflection of the initial filtrate. If it were secreted into the tubule, this number in the urine would be higher than what's being filtered at Bowman's capsule. Are we together? So we had to find molecules that pass from the blood to the urine freely. The original molecule that was used was called inulin. It's a sugar. It can be made radioactive. And for all of those of you who don't remember anything unless you really understand it well, here's how the famous GFR equation is derived. The rate of appearance of inulin in the glomerular filtrate is milligrams per minute in the glomerular filtrate. And over here in the urine, the rate of appearance of inulin in the urine is milligrams per minute at steady state. I'll come back to the word steady state in a minute. Milligrams per minute is a lousy unit. We're going to divide it into two units that are more pliable. One is milligrams per mil, and one is mils per minute. It's the same equation, we're just changing the units. Mils per minute is the GFR. What about the urine? V now is mils per minute appearing in the urine. That is the rate of urine formation. Since the substance is freely filtered, its concentration in the plasma and the glomerular filtrate must be the same. I don't need to know its concentration in the glomerular filtrate. I can look in the plasma because it's freely filtered from the plasma into the Bowman space. So the plasma concentration in milligrams per mil times the filtration, the GFR, glomerular filtration rate, mils per minute, is equal to the amount in the urine in milligrams per mil, the concentration, times the rate of appearance of urine. In other words, how many mils do I pee in 24 hours or in 12 hours? And rearranging the equation, GFR equals UV over P. This is an equation that you must know and you'll remember. UV over P defines the glomerular filtration rate. What does this mean? This is the amount of plasma per minute filtered through the glomerulus that is 100% cleared of inulin, that is discarded into Bowman's space. The GFR is the ability to clear the blood of inulin and throw it into the urine. UV over P is your number. At steady state, what does that mean? Well, it must mean that if there's a sudden blockade in the kidney, what's filtered in the glomerulus when it comes out in the urine could be different. If someone surreptitiously gave another shot of inulin to a patient, the amount going in would be different than the amount coming out. We don't have a steady state relationship. This is a free-flowing steady state relationship. Anything that blocks it, such as acute kidney injury, will take this equation and rip it to shreds. Strictly speaking, this equation must be normal function, normal kidney function, or abnormal kidney function that is at least stable. If it's an acute injury that is changing and things are devolving, you can't use the equation. Strictly speaking, you can't use the equation. So inulin goes in, comes out, very simple. Okay, so inulin is a radioactive molecule. It's not used routinely, probably not used very much anymore. We use an endogenous molecule instead, so nothing has to be injected. The endogenous molecule is called creatinine. There's its structure. It's produced by muscle mass. It's filtered like water. It's not reabsorbed. There is some secretion. We're going to forget about that for the moment. You'll come back to that later when you get to chronic kidney disease section. This is something that's just made by the muscle at steady state, appears in the urine at steady state if the kidney is functioning at steady state. So GFR is U creatinine times V mils per minute of the urine divided by the plasma concentration of creatinine, UV over P. At steady state. Let's take a look at this creatinine, and let's think about some questions that you need to be able to answer. This is bedrock medicine. Everyone knows these things. The filtration rate of creatinine is the product of its plasma concentration times its GFR. Likewise, the filtration rate for sodium is the product of its plasma concentration times its GFR. That's how much is filtered. Yeah, but what's the difference in the final clearance? They are the same. The clearance of sodium is greater than creatinine because sodium is secreted by the tubule into the urine. The clearance of sodium is much less than creatinine because sodium is reabsorbed by the tubule. Neither is a good measure of GFR. What do you think is the right answer? What do you say in the back? C? Who likes C the best? Raise your hands. Right. 28,000 milliequivalents of sodium are filtered. You only pee 5 milliequivalents, 20 milli, 30, 100 milliequivalents of sodium. Most of it is reabsorbed. Creatinine is not reabsorbed. If it were, it wouldn't reflect glomerular filtration because we wouldn't see it in the urine. It would disappear. It would be reabsorbed. So the answer is C. Questions? Clear? You suspect the patient has a kidney disease. You want to measure creatinine clearance. It's important that the creatinine production rate is constant. Is that true? Do we need a constant creatinine production rate? Do we need to be in steady state with the production of creatinine? It comes from muscle. Do we need to, yeah? Yes. A. A is the correct answer. Does Arnold Schwarzenegger make more creatinine than John Barash and Ali Gharavi combined? Here is the governor of California. Does Arnold make more creatinine than I do? Comes from muscle. Right? Do we agree? Okay, you all fail your tests. I'm sorry. Okay, no, I'm sorry. Quite a guy, huh? All right. Next question. Oh, conversely, what happens to an amputee? They make less creatinine a day? Opposite of Arnold. The opposite of Arnold is an amputation, right? Okay, make less creatinine. Okay, good. What samples from the patient are required to measure creatinine clearance? A tube of urine and blood, a time collection of urine, a time collection of urine and a tube of blood, a tube of blood. Answer? C. The urine must be timed. UV over P. The V is mils per minute or liters per 24 hours or something like that. There's a time in there. C is the correct answer. Okay, here's some real numbers. Uh-oh, real numbers. Uh-oh, uh-oh. Time to learn how to multiply. Okay, day 0, day 1, day 2, day 10. Here's the creatinine, 1, 1.5, 2, and 2. This is a real patient. Urine volume, urine creatinine in milligrams. Oh, DL is 100 mils. Nasty, isn't it? These crazy people in that laboratory, going way back into the 1800s, the unit was 100 mils. Be attentive. You're going to have to divide by 100 somewhere or multiply by 100 somewhere. How much urine creatinine is made per day, and what's the GFR? UV over P is the GFR. U times V is how much creatinine there's in the urine in that collection period, yeah? So all we have to do is multiply these two numbers together. Attention to the units, yeah? And that gives us our total urine creatinine per day. If we divide by P, which is here, we end up with the GFR. Let's look at the numbers. Here's the numbers I calculated. Please check it out at home and make sure that this is correct. I get that this patient on day 0 of hospitalization put out 1995 milligrams of creatinine. This person made 2 grams of creatinine a day. How big is a 2-grammer a day? You can tell the muscle mass of a patient by simply collecting the urine and seeing how much creatinine is there. Okay, a 2-grammer a day, I'm sorry to tell you this, has twice the muscle mass that I have. I have 1 gram of creatinine a day, or 1.3 or something, 1.5. Any bodybuilders in this room? Check your creatinine, it should be up there. No bodybuilders? I see a few people turning red over here. I've seen some blushing going on. I don't know what Arnold would be, maybe 3 grams. He's a 3-grammer kind of guy. Look what happens on day 1 to this patient. Look what happens on day 1 to this patient. Less creatinine in the urine. I have a question for you. If there's less creatinine in the urine, where is it? What happened to the creatinine in the urine? Stay in the blood. Look what happened to the creatinine in the blood. It went up. Of course, this is just a sample per 100 mils, and your total body water space is 42 liters if you're 70 kilograms. Okay? So look at, so the less in the urine, more in the blood. Look what happens on day 2 and day 10. We go back up to 2 grams. That's the UV term, by the way. I'm just multiplying these 2 numbers and correcting for the units. It goes back to 2 grams. Look at what happens in the blood. It went up, but then it's stable at 2. All righty? There's going to be a smell of confusion here, right? Look at the so let's calculate the GFR. I'm just dividing by P. The person has a GFR of 200 liters per day. On day 10 of hospitalization, has 100 liters of creatinine per day. 100 liters per day is filtered. This is a theoretical calculation. I'll tell you why in a minute. It's not, you don't get exactly these pure numbers, but this makes the point. What happened to the patient? This patient had what? What happened? The GFR did what? By what percentage? Half. What happened to the patient? They had a kidney removed. Isn't that cool? It's cool, right? But there's one last wrinkle. This patient had a nephrectomy. But there's one last wrinkle. Why is there still 2 grams of creatinine in the urine if they had a nephrectomy? They had 2 grams when they had 2 kidneys. They have 2 grams when they have 1 kidney? How is it possible? Answer? Because what? Someone say it loud. This is complicated. Say it loud. Why do they still have the same muscle mass in their urine with 1 kidney as opposed to 2 kidneys? Because that one remaining kidney has done what? Has filtered double the amount of creatinine. Really? Yeah, look at the blood. The creatinine has doubled. So the remaining filters are seeing twice the amount of creatinine. And therefore, you get the same final product in the urine. Are we good? It's really, really complicated. It's so easy if you just think of it that way. Take out a kidney, half the filters. If there's the same amount of creatinine in the urine, hey, that one kidney had to filter twice as much. Where to get it from? What's in the blood? The creatinine doubled in the blood. It's filtering twice as much. Why does it filter twice as much? Well, it accumulates in the blood until you reach a new steady state. Half the number of filters, double the creatinine, equals the same final product in the urine. So a patient with chronic kidney disease, this patient now has chronic kidney disease. They have a 50% loss of renal mass. And what that means is that, and it's stable, look, it's stable. And what that means is that the remaining nephrons are assuming the role of 2 kidneys, at least in regards to creatinine filtration. It works just fine. If the creatinine continued to be too low in the urine, that means the creatinine would be continuing to rise in the blood. No, this is a new steady state on the basis of 1 kidney. So if I asked you, is urine creatinine a good measure of GFR? Well, let's look at it. This can't be a good measure of GFR because the GFR fell in half, but I still have the same amount of creatinine. This amount is, remember, is divided. It's the plasma creatinine that is a good measure of GFR. That is a relatively good measure of GFR. UV over P, 1 over P, is proportional to the GFR, not the urine creatinine. You can see that from this example. So what you need to know is that plasma creatinine, theoretically, in this general example, is a good measure of GFR. Urine creatinine represents your muscle mass at steady state. So how about this? Plasma creatinine is informative as to whether we reach steady state. Urine creatinine is informative as to whether we've reached steady state. Well, sure, they both are. Look, I've reached steady state. From day 2 to 10, we can say this is steady state. The urine is 2 and 2 grams. We've reached a new steady state. Let's do that one more time. You take out a kidney, you lose half your GFR. Okay, but you still have, eventually going to have the same amount of creatinine in the urine. Why? Because the remaining filters are seeing twice the load in the blood and filter that, and it goes into the urine. If I took out another quarter of a kidney, the same poor guy went back and had half of the remaining kidney removed, what would the GFR do? It was 100 here on day 10 when he got out of the hospital. Comes back, I take out another half of the remaining kidney. What's the GFR now? 50, correct. What did the creatinine do in the blood? Did it go up or go down? Up, because I have less filters. And when it reaches, it will, okay. And what does it go up to? I take out another half a kidney, it goes up to 4. 1 over creatinine is proportional to GFR. This is a hyperbolic function, if you plot it. It goes up to 4. If I take out another half, it goes up to 8. Another half goes up to 16. Let me ask you something. When it goes up to 4 and I measure the urine creatinine, will I still get 2 grams? And it's stable at 4. 4, 4, 4, 4. It goes for months. It's how much creatinine will be in the urine? 2 grams, same amount. Because the remaining quarter of the kidney is now filtering 4 times the amount of creatinine. It freely filters into the urine at that steady state when it builds up. Okay. Why don't we just use plasma creatinine? Who cares about UV over P? Why can't we just follow P? And the answer is shown here. Why not just use plasma creatinine? The answer is that suppose an elderly man or woman or a young child with limited muscle mass has a plasma creatinine of 1. Is the GFR normal? How about a newborn child? If the child has a creatinine of 1, 1 is what I have, 1.2 or something, 1.1. Suppose that child has a creatinine of 1, the newborn. Is that normal? Because they don't have much, a newborn doesn't have much muscle mass, right? So, by the way, a newborn child leaving the neonatal intensive care unit, I know this well from my studies, it's 0.2. It's as low as 0.2, whereas I'm 1.1. So a creatinine of 1 in that child, although it sounds like in the normal range, normal is sort of up to 1.3, 1.4, somewhere in there. A creatinine of 1 is renal failure in that child. In fact, how much kidney function did they have? It went from 0.2 to 0.4, 0.4 to 0.8, right? 0.8 to 1.6. Well, if you get there, you have half, quarter, eighth, 1/16 of the function, 1/8 of the function around a creatinine. Suppose the patient has less muscle mass using steroids. Suppose they're an alcoholic that causes myopathy. The plasma creatinine could be low. You say, hey, they have normal renal function. You can't tell under certain situations. You need the full UV over P to tell. And finally, we all need to read this paragraph together. This describes a hyperbole. Note that the change of plasma creatinine from 0.5 to 1 means a loss of half of renal function. And a change of plasma creatinine from 10 to 20 is another half of renal function. But the former, this is 100% of renal function to 50% of renal function, whereas the latter is 5% of remaining renal function to 2.5% of renal function. Man, we celebrate in the intensive care unit when we lower someone's creatinine from 20 to 10. Their kidneys are getting better. Really? Yeah, they are. They went from 2.5% function to 5% function. That's not the same as 1 to 0.5. It is arithmetically, but the meaning of it, proportionally, is quite different. That describes a hyperbole. So this line is the representation of GFR versus plasma creatinine. It's this half doubling idea. And I need everyone to inspect this slide and really think it through. Look what happens when a GFR goes from 120 to 60. The creatinine goes from 0.6 to 1.2. Guess what? You go to your doctor, he tells you your creatinine's 1.2. That's normal. He'll say that the creatinine, she'll say that the creatinine is normal. You have normal renal function. Well, do you? Well, no. Your baseline was 0.6. You just lost one kidney, the equivalent of one kidney. This is what we call the insensitive range. And now here at end-stage renal disease, where the creatinine is going from 6 to 12 or 12 to 24, it's a very sensitive range. It's over-dramatized. And the range, because look at the change of GFR. It's very small, going from 20 mils per minute to 10 mils per minute, and so on. By the way, dialysis range is somewhere between 15 mils a minute and 10 mils a minute. Somewhere in here, we begin to think about long-term treatment by dialysis. So that's creatinine. We measure it, we follow it. The higher it is, the less renal function. But beware, you don't know the baseline. And beware that you may be confused by muscle mass or medications and so on. So UV over P is the formal way to do it. That's how we measure filtration. Okay. You measure plasma creatinine. You see if it's in the normal range. You scratch your head and say, wait a minute, I don't know the baseline. Let me think about that. Did it really double from a baseline? Elderly people who are malnourished will have lower baseline creatinines. Arnold Schwarzenegger will have a higher baseline creatinine. And one has to be aware of muscle mass, nutritional status, what the baseline was. Do we do UV over P frequently? No, but we do it. It's common. It's not in every patient. It's common. No. Do we measure plasma creatinine and follow plasma creatinine on patients? Every single patient who comes into the hospital has their plasma creatinine measured almost every single day. If it goes up, we get a phone call, right? Something is limiting the GFR, supposedly. Other than that, they must have gained a leg. Maybe they had third legs. Maybe they had a leg transplant. So now they have so much more muscle mass. And in that case, I wouldn't call a nephrologist. I would call someone else to see the patient. Okay. Okay, our assignment now is to get 200 liters of fluid and 28,000 milliequivalents of salt across the glomerulus into Bowman space. And we have to study how that works. Oh, this is dry as a bone. Okay, here it goes. You'll love it, don't worry, you'll love it. It's dry, but you'll love it, okay? What is the movement of a substance due to? I bet you don't remember August 28th, 2014. I bet you don't remember that day. It was in that very dark, frigid room that we used to go into for remember that room? Pandemonium in there, man. I took class notes for 4 months, man. I'm going to put J. Barash, MD, 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 because I have many MDs. I learned something, that the movement of a substance is best thought about it as a flux equation. J is the flux of water, LP is permeability, A is area, and the less part of it is driving force. Permeability times area times driving force is the flux equation. Remember that? Flux. We went over this for days on end. Flux. The flux of water is the permeability of the glomerulus, which can be divided into two parts. The permeability of the glomerular basement membrane, the famous GBM, and the permeability of the slit diaphragm, the area of the filtration apparatus, and the fancy driving force, which is composed of two things. It's composed of a hydrostatic pressure, delta P, and an oncotic pressure, or osmotic pressure, delta pi. And they seem to have a minus sign between them, suggesting that they may be equal and oppositely disposed at some point in the process. Pi, the osmotic pressure, is solved by the Van Hoft equation. Remember this? Reflection coefficient times universal gas times temperature times concentration on one side of the membrane versus the other side of the membrane, with the sigma being the reflection coefficient. Let's talk about permeability of the glomerulus. It's not that hard. So the permeability of the glomerulus is due to these funny cells and how they build up across the structure. Here we have the endothelial cells, here we have the GBM, and here we have the podocytes. Now, it was thought that since these are huge fenestrae, that this is the leakiest capillary in the universe. It's been more recently, there's some recent papers showing that these are heavily glycosylated surfaces with negative charges that tend to repel. You know, most serum proteins are negatively charged, so they're actually repelled even though there's large fenestrae. Meanwhile, this space allows small molecules in water to transit. This is the glomerular basement membrane, which is a permeability barrier. It's also negatively charged, reflects negatively charged proteins, have a hard time going through it. And finally, we hit the podocyte foot processes, which are attached to each other by junctional complexes known as a slit diaphragm, and this too is a permeability barrier to the movement of substances into Bowman's space. Bowman's space is on this side. This is the blood side. And 200 liters a day right there. Okay, the famous experiment that you'll probably see a million billion times. If you are a large protein, you don't clear through the glomerulus. Albumin has a very poor clearance because it's 66 to 68,000 molecular weight. If you are a negatively charged substance like dextrans sulfate, you tend to be not cleared. You can't pass the glomerulus. If you're a positively charged substance, you get the opposite effect. It goes right through the glomerulus. So large negatively charged proteins, they don't go through the glomerulus very well. Are there any proteins that are positively charged in our body? There are only very few classes. Do you know one of the classes that are positively charged? It's really interesting. You learned about it in immunology. What? Antibodies are positively charged. Did you know that? Light chains are positively charged. They tend to be filtered and make it into the urine pretty well. But most of your serum proteins are negatively charged, and so they don't enter. Over here we have a sense of a disease that doesn't abolish the molecular weight selectivity, it abolishes the charge selectivity. Here's the famous experiment of Marilyn Farquhar, which basically started modern nephrology. What she basically found is that she delivered a negatively charged ferritin particle, and they seem to stay in the capillary. There's very little in the GBM, nothing at the slit diaphragm, nothing in Bowman's space way up here, Bowman's space way up here. However, if you perfuse the rat with heparidinase, which cuts off the sulfation, the sulfation rather, of heparins, you can see more of these negatively charged particles entering the glomerular basement membrane. The positively charged ones enter and stick to those negative charges in the GBM, and if you cut those off with heparidinase, you get clearance. What this experiment showed is that negatively charged substances don't even pass these endothelial very much, this endothelial barrier, even though they have big fenestrae. Look at that. Look at the difference, the gradient of particles here. And so we have negative charges reflecting these proteins and keeping them out of the Bowman space, which is on top. So here are our negative charges in our endothelial cells. Here's our glomerular basement membrane. The podocytes attach to the GBM by virtue of these integrins. And these integrins hold the foot process down, but they're also signal transducing elements because someone did a great experiment. They took antibodies against this integrin. They put a magnetic bead on that antibody, and then they put a magnetic field across the animal and twisted the integrin, moved the integrin in space through a magnetic field. And what they found is a whole bunch of gene expression inside. So these don't only hold here, they're thought to be generally sensors of mechanical stretch, of pressure coming from the blood side, of blood pressure, in other words, regulating various components in the foot process. So foot processes are held by integrins, standard alpha beta dimer, heterodimer, activated integrins. And the GBM itself, and you'll have many lectures on this from world-class experts, such as Dr. Kirlock, sitting in the back, who will talk to you about glomerulus in great detail, and Dr. Garavi, but here is a quick view into it. There's a disease called Alport's, which is a missing non-collagenous domain in collagen 4. That's bad news. And the reason that's bad news is that it's not only this collagen that's defective, but there's a whole group of collagens that associate with it that now have a very short half-life because they can't bundle correctly. And that's what the GBM now looks like. It's split into two components. This changes the permeability of this glomerular basement membrane, increasing it. This structure is leaky. A defect in laminin beta-2 is called Pearson's disease likewise. The GBM is under continuous attack by many things. Remember, immunoglobulins are positively charged substances. They go right into the GBM. Here they are accumulating in this disease called membranous. This is a very destructive event and causes the glomerulus to be leaky to proteins. That's called nephrosis. They leak across into Bowman space. So if you're a podocyte, you better have an integrin. If you're an endothelial cell, you better be negatively charged. You better have an integrin on the podocyte. Your GBM has to have correct collagens and laminins bundled together and can't have these immune deposits. Otherwise, permeability increases abnormally. The junctional complexes that go from one foot process to another will be discussed in detail in this course. There are 3 or 4 incredibly important proteins discovered through human genomic projects. They are called podocin, nephrin, neph here. And these are involved in forming what is called a lipid raft. You remember that this type of protein that doubles over in the membrane is very typical of apical membrane proteins that traffic in cholesterol-laden, ganglioside-laden patches of membrane that float up to the cell surface. Remember, that's an apical trafficking process. And podocin is a key molecule in maintaining those lipid rafts. It associates with nephrin and neph, which are adhesion proteins across this podocyte-to-podocyte space. They form homo and heterodimers with each other. And these molecules are critical because when they are abnormal in humans, one gets nephrosis, the leaking of proteins into the urine. They also, of course, like integrins, are signaling proteins, and they signal through a set of proteins known as the WASP protein. Remember that guy? WASP, Aldrich protein, right? The Wilcott-Aldrich disease. This is a protein that activates actins, remember? And it's downstream of CDC42. Remember that? And what happens is that these associated proteins signal through these mechanisms to bundle actin correctly. There's an adapter protein that bundles that is defective. Even these systems are incredibly important because when defective, cause nephrosis. A PNS student who used to sit in that back row there, ready to exit the room, way long ago, named Andre Shaw. He used to sit next to me. We used to read the New York Times together. In any case, he was always ready for exit. He discovered CD2AP in lymphocytes, and he found that when he knocked it out, he got nephrosis. He came back to Columbia a few days ago and said he never wanted to be a nephrologist, but here he is with a key molecule in these podocytes. Finally, these molecules are under a variety of other signals. There are calcium channels. One is called TRPC6. And so on. And here's your mutations of these important adhesion proteins. Nephrin, 1 in 10,000 births. It's called Finnish nephropathy, more common in Finland. Mutations in podocin, failure to form the lipid raft, and so on. The purpose of these slides is to give you an introduction into the permeability barrier and the fact that one cell, huge basement membrane, and cells here are required to form it. That's permeability. Area of the glomerular basement membrane is something that we don't tend to talk about. We will in 2 minutes. It's said to be controlled by mesangial cells. These are the cells that are between the capillary loops and can contract and therefore reduce the space of the circle. They are under the influence of a variety of circulating hormones. And we generally don't consider that, but I think that it's going to be sort of a frontier area of nephrology to think about that, because I have a feeling that not all nephrons are used equally all the time. And some of them may be shut down, and some of them may be protected from environmental insults, and some may be more subject to them. And I have a feeling the contraction of the mesangial cell is involved. And finally, the big guy, the big elephant in the room. The driving force, hydrostatic minus oncotic. This is exactly the same slide you saw in MM, and what it shows is a definition of hydrostatic and oncotic pressures. Hydrostatic is the pushing pressure from the heart. It's driving blood into the glomerulus, giving it a blood pressure in the glomerulus. We'll see that in a second. The osmotic, or if we're talking about proteins, the oncotic force, has to do with water activity. Remember this concept that water can diffuse pretty easily. But if you put a sodium atom here, it's like Jupiter with moons around it. Water will organize in these structures around the sodium nucleus, around the chloride nucleus, the potassium nucleus. And that water that's in electrostatic interactions with the sodium is less likely to diffuse. Therefore, if you have salty water, that water is going to sit there. It's organized by the sodium. And in fact, if it's across the membrane from another batch of water that doesn't have sodium, the water will flux from that high water activity, that clean water, into the salty water. And as it does so, it will create a pressure in that second compartment. If I stood there and put up my fist and force that water to go back, the pressure that I would have to exert to push the water back is called the oncotic pressure. It's the equal and opposite pressure that I need to retard the movement of water into a low water activity pool. So this pool over here with the glucose is a low water activity pool, and the clean water is going to move into it. Water is going to rise up the manometer, and I have to put pressure on that manometer to stop the movement of water, even to force it back the other way. The Van Hoft equation is an equation that's quite brilliant, because what it does is it says that the movement of water is due to the concentration of the thing that's making the water chelated right here, the glucose molecule. That's C. Now, the reflection coefficient is also very important, because if glucose just wandered right across this membrane, then it would be useless as a fixed osm to bring water, to chelate more water on one side of the membrane. It would go across on the other side and chelate water there as well. So you better have a good reflection coefficient, meaning that it doesn't cross membranes. Reflection coefficient of 1 means no crossing in the membrane. 0 means water. It just goes right across. Okay. Here is, on this slide, is the way that we think about glomerular filtration. Permeability times area times the hydrostatic pressure in the glomerulus minus the hydrostatic pressure in the tubule minus the, well, we're talking about the same molecule, so only one reflection coefficient, the osmotic pressure or oncotic pressure remaining in the glomerulus versus the oncotic pressure in the tubule. And those are our driving forces. Good news, PT is very low and pi t is very low, and we just throw them out of the equation. So the GFR is permeability times area times PGC, GC is glomerular capillary, minus pi GC, hydrostatic minus oncotic in the glomerulus. Recognize the fact that when PGC equals pi GC, this equation goes to 0 and filtration stops. Here's a real live example. Here's the afferent arteriole coming in, and here, in fact, is the hydrostatic pressure at 50. The oncotic pressure here, which is drawn by an arrow facing the opposite direction, is 20. And then there's some back pressure, there's some back hydrostatic pressure in Bowman spacing in the tubule. They say it's 15. So it's 50 minus 35 is the outward driving force, millimeters of mercury. 15 millimeters of mercury is what you have to work with when you enter into the glomerulus. Notice what happens. That 15 millimeters of mercury forces water out. That means that albumin and other large proteins get concentrated. You see the circles seem to get concentrated here. And that means the oncotic pressure rises up to 30, from 20 to 30 millimeters of mercury. And so the back pressure here is 45. The outward pressure, the hydrostatic pressure, is still 50 minus 45. It's only 5 millimeters of mercury at this point. And guess what? If we go a little bit higher on the glomerulus, the pressure relationships are equal and opposite and all filtration stops, and that point is called filtration pressure equilibrium. In other words, the blood comes in with a pressure head. You filter out the water and the small molecules. You retain the big guys, which retard the further movement of anything leaving. And that point is called filtration pressure equilibrium. This slide also suggests that we don't necessarily use the entire space of the glomerulus to filter. There's a point at which that filtration pressure equilibrium arrives and all filtration stops. Think the mesangial cells probably control that size and that shape. Okay. This is a graphical example that I'm going to use quite a bit in the next lectures and so on, and let's take a look at it. This graphical example shows the following. The height of this column is the pressure arriving in the glomerulus. Oh, one thing I need to tell you. You notice the hydrostatic pressure is 50 here, it's 50 here, and it's 50 here? That's the only place in the body that the hydrostatic pressure will not decline through a capillary bed. It's the only place in the body that that occurs. There's a maintenance of the hydrostatic pressure. Every other capillary system you learned about has a declining hydrostatic pressure through friction and so on. Not here. It's maintained. We'll go into that in detail in a minute. But it's the only place in the body that this occurs. So, hey, I wrote 40 here. Look, it's constant throughout the length of the glomerulus. This is the afferent arteriole. This is the efferent arteriole. It's constant. So that's the pressure head forcing fluid out. Now, as I force fluid out, the oncotic pressure rises in that blood, blood space of the glomerulus. This is the rise of oncotic pressure. Yeah? And the driving force for GFR, the glomerular filtration rate, the driving force for it is the difference between hydrostatic and oncotic pressure. So if I look at the area in this diagram between this line right here and this line right here, that's the driving force for the GFR. The difference between the constant hydrostatic pressure, way up here, and the rising oncotic pressure. That area is a graphical representation of the pressures that cause the GFR to occur. You notice that it doesn't go throughout the whole length of the glomerulus. It sort of stops in the middle. That's because they become equal and opposite. And that's called filtration pressure equilibrium right there. Any questions on this graphic? Yes?
I have a question on the previous slide. Why does the concentration
Because of these small circles are things like albumin. And remember, we forced out the water. So we are evaporating, or we're pushing water out into this tubule. And so the proteins remain and are more concentrated there. You notice that's why the oncotic pressure goes from 20 to 25 to 30. The oncotic pressure here rises as we push water out. This is now concentrated proteinaceous solution. And that doesn't allow any more fluid to leave because your hydrostatic pressure is equal and opposite to the oncotic pressure at this filtration pressure reversal point, equilibrium, which is shown right here. Does everyone understand this graphic? It's essential to understand the graphic for us to go on. The height of the column is the hydrostatic pressure. It's maintained. And the rising oncotic pressure is going to do the opposite, retard the export of molecules, of small molecules into Bowman space. Space is called the driving force. It's the driving force of the GFR. This space right here. Okay, so the kidney has a number of things that it must do. And in order to remove excess sodium, water, and potassium, and protons, and so on, it must filter 200 liters a day through this hydrostatic and oncotic pressure relationship. And it must deliver those into the tubules to throw away. The key thing that will be obvious now is that while the glomerulus is sort of stupid, right? It just filters all these things. The question is, what is the tubule going to do about it? And so the action, the thought process, the cognitive stuff happens downstream in the tubule. It turns out that there's a relationship of the glomerulus to the tubule which is quite complicated, and we'll do that on Monday. But in essence, the key thing is that to maintain balance, we must deliver all of this material and then let the tubule make some decisions on it in order to achieve a balance. So we're going to take a 3-minute break, and then we do the next lecture, okay?
Have you heard of supplementing creatine?
Sure.
So
It will
what are the cons-
nothing. So it will raise your plasma creatinine briefly,
Okay.
and obviously that will be filtered and thrown away. There is no consequence that I know of. I don't know that it builds muscle mass. I think this is all placebo. Yeah, all this stuff is garbage. Is what I understand.
I know it's contagious.
I don't think that you have a deficit in energy storage in your body. Therefore, you don't need another source. Creatine phosphate is a way to store energy in cells. A lot of the phosphate donors that we have is not ATP, it's actually creatine phosphate. It's a storage pool. It's unlikely that you have a storage energy deficit. So, in fact, I'm sure you're saturated. So why would you need excess? People do, there may be mythology. Why don't we look up the literature? Why don't you just go to PubMed.com and check it out and see if anyone has actually built muscle independent of exercise. So you have to take a couch potato before and after creatine. Right?
Yeah.
I think most of the stuff is going on in here, which is fine. It's not dangerous. It's endogenous compound.
Yeah.
Okay. I don't understand that people make billions of dollars on giving you what's in your body already.
Oh yeah.
Well, I mean, look at these companies, Poland Spring, they sell water after all. I mean, it's like, someone's really smart. Yeah. You see what I mean? There's not much known about that. So there are nephrons that are way down towards the medulla, and there are nephrons that are way up to the cortex. The architecture of the blood vessels that surround it is quite different, and one would suspect that they have different functions, different blood flow. This becomes a great concern to people who are interested in acute kidney injury. Someone having a pet, and while some patients survive, I inject you with bacteria with 50% chance that they're really recovering. So why does 50% of patients completely escape damage or escape major damage? And why does 50% have major damage? One would suspect that some have so that's the idea. I don't know if they and one reason I never paid attention is that when the mouse mice, the model that I was the mouse kidney is much more simple in terms of architecture. So you can't actually get out of really robust organisms. Previous lecture?
Yeah. Previous lecture. Oh. Well, it doesn't matter if you can't pull it up. But my question, I understand why the oncotic pressure.
I'll be able to pull it up. Huh. Probably should have touched anything.
That's okay. Oh,
There you
now you need to figure out how to get back to where you were.
Wait a minute. Oh, this is good because the lecture should be here. Introduction to balancing the tube. Oh, balancing the glomerulus is where it is. Yeah. Let's pull that out. Yeah, that's your guy.
So it's, there we go. It was like the further down.
Yeah.
There you go.
Yep. This slide?
Oh no, let's see. Keep going down.
That one.
This one.
Yep.
All right, so I understand why as water leaves, the blood here gets more concentrated,
Yep.
and so the oncotic pressure changes.
Yep.
I don't understand why,
The
despite the
hydrostatic
fact that
remains
the
the
water
same.
leaves,
Right.
the hydrostatic pressure remains the
Right,
same.
it should decline. And in every capillary it would. It doesn't here, and we're about to go through that in great detail now. The reason is the efferent arteriole contracts.
So you have a
Pressure head bump proximal to it.
okay.
You got it?
So the afferent's more dilated than the efferent.
That's correct.
Okay.
So it's a real weird system of even though you're draining out the fluid, the pressure should go way down. The efferent
It's a
arteriole
narrowing
continues,
tube that-
continues to maintain that pressure.
Okay. Cool.
Yeah.
Thank you.
Only place in the body that
And I
happens.
guess that's where like all the various hormones act.
Exactly. We're
Okay.
about to do this in great detail. Okay, why don't we do our thing? All right, why don't we grab our seats? Very good. So, this is our big lecture now. This is the hard one. Okay, so to remain in balance, we must filter. And we filter through the glomerulus, and it's under hydrostatic pressure and oncotic back pressure. And we're going to deliver gigantic amounts of fluid to that tubule. And the way to take a look at it is through this diagram. Makes it easier once you get the graphics. The height is the hydrostatic pressure. It is maintained continuously throughout the length of the glomerulus. I'll discuss that in a minute. Forcing fluid out, creating a higher oncotic pressure, which is the remaining pressure of the protein that remains behind. And the driving force is the difference between hydrostatic and oncotic pressure, hence the area that is shown here. It's just a graphic way to show an amount of driving force. 3 hormones control glomerular hemodynamics: angiotensin II, norepinephrine, and antinatriuretic factor, ANF. You have to learn 3 hormones. When the extracellular fluid is depleted, angiotensin II and norepinephrine rise and act on the glomerular vasculature. Conversely, when a patient has too much volume, we'll discuss this in great detail later or on Monday, the atrial natriuretic factor rises and acts in opposition on the glomerular vasculature. Here's the problem. Here's the afferent arteriole. It's under regulation of antinatriuretic factor and norepinephrine. Here's the efferent arteriole. it's under influence of angiotensin II mostly and norepinephrine. In the middle is the pressure of the glomerulus, called PGC, which is equal to hydrostatic minus oncotic. And it's the dilation or constriction of these two arterial beds that control the pressure relationships in the glomerulus and determine how much is filtered. So let's take a look at atrial natriuretic factor or peptide, ANP or ANF. It dilates the afferent arteriole. It comes from the heart under stretch, by the way. It dilates the afferent arteriole. This increases renal blood flow. Think, afferent arterial dilation, renal blood flow increases. This increases the pressure in the glomerulus by transmitting systemic pressures. In other words, if you look at the previous chart, you see that the pressure here is indicated by the number 50 millimeters of mercury. But if we dilate the afferent arteriole right over here, this set point could be higher at 60, or if we constrict, would be lower at 40. And that depends on ANF versus norepinephrine. If we dilate the afferent arteriole, we're bringing higher systemic pressures to the glomerulus. This increases the pressure head, but it also, maybe even more importantly, decreases the oncotic pressure. Why? Because it's bringing so-called fresh blood at a faster rate into the glomerulus. So the blood doesn't have a chance to be concentrated to the same degree. In other words, filtration pressure equilibrium is never reached. And this increases the GFR. Let's look at the graphic. It makes it easier. If you're dilating the afferent arteriole, the pressure head is higher because your central pressure is now transmitted all the way to the glomerulus. So the column here is higher. That's a higher hydrostatic pressure. The oncotic pressure, of course, rises as you're forcing fluid out. But look, it never reaches reversal pressure equilibrium. It never comes to this point. The difference between the top line and the rising oncotic pressure is a much bigger space. So the driving force on GFR is increased. In other words, you filter more. That's what ANF does. It suppresses the rise of the oncotic pressure by bringing fresh blood. It gives a higher pressure head at the same time. The difference is bigger. Let's look at the opposite side. Angiotensin II is a derivative of A1 angiotensinogen from the liver through two enzymes, renin-converting enzyme. It operates mostly at the efferent arteriole and causes constriction. Let's see what happens. If I constrict the efferent arteriole, my pressure in the glomerulus, which is upstream, would rise, correct? I'm downstream of the glomerulus. If I constrict it, the pressure upstream rises. But notice what happens to the renal blood flow. It decreases. Makes sense, right? You constrict the efferent, the renal blood flow is decreased. Therefore, I'm not bringing that fresh, delicious, unconcentrated blood. And it concentrates nice and fast. Pressure head is higher, the blood flow rate is lower, and I get more concentrated blood in the glomerulus. The oncotic pressure rises very fast, and then the area between the hydrostatic and the rising oncotic pressure, the driving force for GFR, is nearly identical to the one in the control circumstance. So you can see that GFR is probably not changed. Sounds, again, pretty stupid. Why would I want to do this? We're going to come to it in a minute. Because the GFR is not changed. ANF sounds pretty good to me. If I have excess fluid, I want my ANF to afferently vasodilate, bring more pressure to my glomerulus, decrease the oncotic pressure here. I want to have a bigger GFR so I can pee more. This wouldn't do that. The GFR is unchanged. Let's go to norepinephrine. Norepinephrine constricts the afferent and the efferent arteriole, both. And so there's no change in the pressure heads because they're both clamped. But renal blood flow is diminished. You can imagine constricting both would decrease renal blood flow. And this certainly would cause a rise in oncotic pressure. There's less clean blood coming here. And you can imagine that the GFR is therefore smaller. The driving force on the GFR is smaller. Because you're clamping both sides and you're cutting down the renal blood flow, and therefore the blood gets more concentrated faster. So let's review. The driving force normal here is decreased by norepinephrine. You will be giving your patients norepinephrine in intensive care units. Guess what? In every single patient, you will limit the GFR. That's called renal failure, right? You will cause renal failure by giving norepinephrine to all of your patients. Angiotensin 2 seems to change the pressure relationships, but not the GFR driving force. And ANF increases the GFR driving force. Now, there is something on the bottom of this slide here called filtration fraction. I don't know if Christoph uses that in the way he's running the course, or Dr. Gravi uses that. But sometimes it's a good bookkeeping tool. It's the GFR versus the renal blood flow or renal plasma flow. It's a bookkeeping tool. It's an arithmetic tool. And I'm going to run through a few slides using it. Not everyone uses this concept. I mean, if you want to have two variables and describe them independently, that's fine. But some people combine them in a ratio and derive this kind of ratio. So norepinephrine decreases the GFR. Why does it do that? It decreases the renal plasma flow. And so if you divide the two, there's no change in filtration fraction. ANF increases the GFR. It increases the renal plasma flow, renal blood flow, either to the same extent or to a greater extent. So there's either no change in filtration fraction or there's a decrease. Angiotensin 2, which is the reason that we use filtration fraction, because we want to understand A2 very well, is there's no change in GFR because the renal plasma flow falls, even though the GFR, this should actually go up, or there's no overall change. So there's more outward pressure, but there's more back pressure because the renal plasma flow changes. So renal plasma flow goes way down for no change in GFR. The filtration fraction increases. You need to look at the slide and think through the numerator and the denominator. As I say, you don't need to do this, but frequently you will hear this, and sometimes, if you get used to it, it's kind of a useful tool. Okay, here I have a question. Why does an increase in renal blood flow, like with ANF, ANP, increase the GFR when it's not even in our driving force equation? GFR is proportional to area times permeability times driving force. Here's the driving force right here. There's no renal blood flow mentioned. Well, why does it change the GFR? Why does it increase it? A, it's because of permeability in the glomerular capillary. B, because urinary pressure falls. C, because of glomerular capillary pressure falls. Glomerular oncotic pressure falls. Glomerular capillary pressure rises. Good answers are D and E, as shown there. In other words, when you dilate and you have a higher transmission of pressure, the hydrostatic pressure goes up and the oncotic pressure falls as you're bringing more blood into the system. So D and E both apply to a situation like atrial natriuretic factor. Higher minus lower. That's a big change in GFR. Here is a thought experiment by a colleague, Juan Oliver. Let's take a look at this slide briefly. Please review this slide on your own. It's just looking at arithmetic. You ready? Let's look at it briefly. If renal plasma flow is 100 nanoliters per minute, and at some given distance along the glomerulus, we filter out 20 nanoliters per minute, thrown away in Bowman space. Therefore, the concentration of protein when you leave the glomerulus will have increased by 25%. Why? Because I just took away 20 nanoliters of water. and left the protein behind. 20 nanoliters per minute of water. If my renal blood flow, however, is 200 nanoliters per minute, and I still take away 20 just the same, which is this condition right here, then I only have 11% increase in my protein concentration. You can do the numbers. Those numbers are correct. In other words, the more renal blood flow, the less change in concentration of protein you'll have over the course of the glomerulus. That means you'll have lower oncotic pressure, less back pressure, therefore more GFR. So simple arithmetic gives you the answer. Okay, next point. Please study that slide on your own. You have to look at it and do the numbers to get it. How does angiotensin II change glomerular hemodynamics? 1, A2 decreases the renal plasma flow, increases the pi-GC, and reduces the GFR. 2, angiotensin II increases the PGC, the pressure head, and increases the GFR. And 3, 1 and 2 apply, and hence no change in the GFR. What do you say? Here's the picture of what angiotensin II does. What do you say? 1, 2, or 3? 3 is correct. It decreases the renal plasma flow by constricting the efferent arteriole, increases the oncotic pressure, and therefore reduces the GFR. But, on the other hand, it gives you a higher pressure head, which enhances the GFR. So when the two subtract each other, and there's no change in the GFR. Is this all made up nonsense, crazy stuff? I once had an anesthesiologist tell me, that's garbage you teach. Why are you teaching that garbage? Okay, here's the real experiment. When you infuse angiotensin II, or put the patient on a diet which is equivalent to having a high angiotensin II, a low sodium diet, you'll learn about the connection in a few minutes. The GFR doesn't change. Single nephron GFR doesn't change. The blood flow decreases. And the pressure in the efferent arteriole, the resistance in the efferent arteriole rises. Afferent slightly, efferent has a big rise in pressure. And the pressure head in the glomerulus goes right up. So down renal blood flow, up pressure head, no change in GFR. This is all due, well, mostly due to constriction of the efferent arteriole right here. This is real. Angiotensin II is one of the major regulators of glomerular pressure. Okay. At this point, you should say, okay, that's pretty boring. Why do I need to know that? And who cares anyway? And those are really good questions, and they're going to take a few minutes to answer. And we're going to answer them not in the glomerulus. It's pretty paradoxical. We're going to answer them instead in the tubule. And the reason that is that the stuff we just talked about, remember that the efferent arteriole comes out of the glomerulus, wraps those capillaries around the tubule. That's the peritubular capillary system. And what we just did in the glomerulus is going to impact on the proximal tubule. So we exit the glomerulus, and we put all this fluid here. The proximal tubule is responsible for reabsorbing 67% of the sodium chloride and water that you just filtered, almost all the bicarbonate that was filtered, almost all of the glucose and amino acids that was filtered. It reabsorbs filtered proteins. It has secretion of some small molecules as well. This is crazy, right? This is why I didn't understand nephrology as a PNS student. I had no clue as to what was going on at this point in the course. Made no sense. You know, I decided to study it, and I liked it so much that I turned into one of these people. So anyway, so we filter so much, then we reabsorb it all. It's like, why are we, it's a stupid organ, okay? But let's take a look at that process. This is the efferent arteriole, and it breaks into these plexuses. Isn't it extraordinary? It's feeding the same nephron from which it came. And that plexus surrounds the proximal tubule here, and the thick ascending limb here, and the collecting ducts here. And it's the same efferent arteriole that gives rise to all these plexuses. In other words, whatever we did in that blood system in the glomerulus is about to be referred downstream around the tubules. Here's the effect of angiotensin II, by the way. So this is the efferent arteriole right here. It becomes really, really skinny. Here's the efferent arteriole here. Nice and thick. It becomes really skinny when you add angiotensin II to it. It constricts, raising the hydrostatic pressure, but also the oncotic pressure as well. All of that is going to be seen by these vascular beds. And here's the answer to the questions of why is the kidney so stupid? The answer is right here. And why is angiotensin II do something that seems to have no effect on the GFR? The answer is in this slide. This is the key slide. Let's go through it. Here's a normal situation. This is the glomerulus. Here's the pressure relationships around the tubule in the peritubular vasculature. This is under normal conditions. This is under angiotensin II conditions. Can someone help me and describe the slides? What do you see here? Can someone talk me through the slide? Help me out. Let's start with this line. This line is, which pressure is this line? Okay, when we get to the peritubular, right after the efferent arteriole, as we go to the peritubular capillary, this line is oncotic or hydrostatic right here. Oncotic, because it rose up to this level, and here it's falling over the space of the peritubular capillary. What's this pressure right here? It's the remaining hydrostatic pressure in the system. I have a question for all you guys. Why is the hydrostatic pressure, it's this high, why did it fall to such a low level over here after the efferent arteriole? Why do we have a loss of pressure after the efferent arteriole? Post-resistor, you're quite right. So the efferent arteriole is a resistor maintaining the pressure head in the glomerulus, but afterwards you have a crash of pressure, and the hydrostatic pressure is less. So let's look at the slide. In the glomerulus, the hydrostatic pressure dominates the oncotic pressure. In the peritubular vasculature, the oncotic pressure dominates the hydrostatic pressure. It's exactly the opposite. Do you get it? That means fluid doesn't exit the vasculature. What does it do instead? It means it goes into the vasculature because the oncotic pressure is really high in there. This is the mechanism by which you reabsorb 67% of the filtrate. Okay, look at angiotensin II. See the difference? Yep, the hydrostatic pressure was higher. What did that do? That squeezed out more filtrate from the blood. That left a higher oncotic pressure here and a higher differential between oncotic and hydrostatic in the peritubular capillary. So, to summarize, what angiotensin II is doing by constricting the efferent arteriole is afterwards it creates a bigger pressure drop, but at the same time is sending blood out that's more concentrated. Now remember, renal blood flow reduced, and that's why the GFR didn't change or went down or stayed the same more or less. So what angiotensin II is saying to the kidney is, please process less blood. But that blood which you process will be more concentrated. Yes, you'll squeeze out the same 200 liters into the proximal tubule. But that's smaller amount, you'll operate on a smaller amount of fluid because the renal blood flow is reduced. But from what you do transit into the glomerulus will be squeezed to a greater extent. You will bring out more fluid from it, leaving a higher oncotic pressure to go into the peritubular capillaries to cause more reabsorption. You may say, wait, what? You should say, what? What's that all about? Let's do that one more time. The purpose of the kidney, remember, is to keep you in balance. You are eating so many toxins every day. If you need angiotensin II, we'll talk about why it goes up. Angiotensin II is an emergency hormone. It's absolutely essential. Without A2, nothing, you wouldn't probably be able to stand up straight. Right? It maintains blood pressure, does a lot of things. If it rises, what it's saying to the kidney is, please continue to filter your 200 liters a day. But I'm going to take that from a smaller blood space. And by doing that, I get a higher concentration, which means I'm going to reabsorb more of the 200 liters when I exit. It maintains the GFR. You continue to get rid of the junk that the kidney normally gets rid of, but you increase the reabsorptive capacity of the kidney. Let's take a look at this slide. This is, again, a beautiful slide from Juan Oliver, who has written a simple arithmetic. The arithmetic is based on the filtration fraction. 20% is normally filtered, so the filtration fraction is normally 20%. Under the influence of angiotensin II, it goes to 25%. That's a smaller amount of blood, but the greater degree of filtration from that blood. He asks simply the question, and please go over this yourself, he asks simply the question is, well, what's the albumin concentration coming out under these different conditions, this afferent and efferent? In the normal case, it's 6.25 grams per DL. It's some gigantic number. We have tons of albumin. However, in the presence of angiotensin II, the number rises to 6.67. The higher filtration fraction means get rid of more for less renal blood flow. Therefore, you end up with more concentrated blood. The albumin has gone from 6.25 to 6.67. In the presence of ANF, which does the opposite, it goes down to 6. The difference in protein concentration, therefore exiting the efferent, going down the peritubular capillaries, represents enough of a change of oncotic pressure to drive increased reabsorption. Remember this, if you change something by 1%, well, 1% of 200 liters is 2 liters. That's huge. Why is it huge? Well, because the most you usually pee is about 2, you pee about 2 liters. A 1% change in reabsorption is an additional 2 liters that's been reabsorbed. So slight changes in albumin drive tubular reabsorption. So is angiotensin II stupid? It seems not to change the GFR. It's brilliant because it doesn't change the GFR. It allows you to get rid of junk, at the same time reabsorb more of the good stuff, the water, the proteins, the salts. It resets the equation. That gives us, it maintains homeostasis at the same time, reduces our eventual excretion of salt and water. We want angiotensin II when we need to reduce the renal output. Intake minus non-renal output minus renal output tends to 0. We want to reduce our renal output, and angiotensin II is the main way we do it, by increasing albumin in the peritubular capillaries. One can approach all of this by looking at the peritubular capillaries. I just want to point out that the driving forces are this way in the glomerulus and exactly the opposite in the peritubular capillary. Oncotic will dominate there as opposed to hydrostatic. And here's a little picture of it. Here's the tubule. Here are the epithelial cells. Here's our oncotic pressure right here. And we'll draw water in this direction. There are a number of molecules in the circuit. We're going to take a look at them now. But the main way to reabsorb water is through albumin being increased here. One of the things that we have to accomplish in discussion of this system is a question of how reversible is it? Do you just, is it like a or can it revert? Is there some back and forth exchange? And the answer is that in many situations it seems to be the latter. The reason is that, which adds complexity to the conversation. The reason is that you remember that epithelia are stuck together with tight junctions. And you remember, I think we reviewed the idea that there are two sets of tight junctions. There's the tight junction and there's the leaky tight junction. Okay, so the tight junction doesn't allow much fluid or movement of substances across between the cells, which is the paracellular space, whereas the leaky tight junction does do so. And as shown in this cartoon by this arrow, this is a leaky tight junction system. So there is the possibility that we're not going to do such a great job, and that really refers you to the fact that you need the constant driving force of the oncotic pressure here to make this system work. The proximal tubule is different from every other segment where tight junctions do not permit paracellular movements. Here, a lot of this action is going through the paracellular space in response to albumin. And I put the equation back here just to remind us that oncotic pressure dominates hydrostatic in the peritubular capillary. Okay. So we've just reabsorbed 67% of the water that was filtered, of the 200 liters that was filtered. And that leaves us, with 23% of the water left over. And it leaves us with 28,000 milliequivalents of sodium and 4,200 milliequivalents of bicarbonate. There's obviously additional mechanisms that need to reabsorb so we get down to the final urine. The rest of nephrology is on the basis of identifying ion transporters. The nephron is really just sort of a conveyor belt of different ion transporters. It's not exactly a linear event, though, because one aspect of the nephron deeply impacts on another aspect of the nephron. So we are quite happy to learn that most of the sodium that's reabsorbed in the proximal tubule is under the influence of angiotensin II again, just like the albumin, just like the water business. These transporters are activated in the presence of angiotensin II. Not only does albumin build up in the peritubular capillary, but there's an increased number of sodium glucose and sodium hydrogen transporters. Let's look at the sodium glucose for 1 minute here. Remember this molecule, SGLT. You learned about it. When it's defective in the intestine, you got to feed your kid not glucose. Remember this? You got to feed your kid fructose or something, because that goes through a different pathway. So this is one of the SGLTs right here. And this is a very nice molecule that picks up sodium, drives sodium into cells. At the other side of the cells in the basolateral surface, we get rid of it by the sodium-potassium ATPase. You notice also that, beautiful, we pick up all of our glucose and amino acids by the same mechanism. They're syncopated. In other words, you know, the rhythm of sodium uptake is the same rhythm of glucose and amino acid uptake. There's an additional transporter here that's under the influence of angiotensin II. It's called the sodium hydrogen exchanger. We'll come to that in 1 second. So not only do we move water, but we move sodium. Here's the sodium hydrogen exchanger in more detail. And these are all slides from Kais Alicante, who will lecture you in a few weeks from now. So this is a sodium hydrogen exchanger. Sodium enters, hydrogen leaves. Okay, bicarbonate, there's 4,200 millimoles of bicarbonate that's filtered. The hydrogen ion combines with the bicarbonate to make H2CO3, which undergoes a decomposition reaction, dehydration reaction, sped up by a cell surface molecule known as carbonic anhydrase. Carbonic anhydrase allows this reaction to take place quickly and releases CO2 in water. CO2 is a gas and diffuses into the cell, whereupon it meets a different carbonic anhydrase, whereupon it becomes H2CO3 again, decomposes to a proton and to bicarbonate. The proton enters into this catalytic cycle, and the bicarbonate exits with sodium at the basolateral surface. So when you have high angiotensin II levels, you stimulate sodium reabsorption, glucose amino acids, and bicarbonate reabsorption, all in a pattern that is mutually regulated, that is tightly controlled together. It's the same process. This uses a proton. How clever is this? Look, we take a salt, bicarbonate. That's the stuff that was in that beaker. We add an acid to it. It fizzes off. Remember the carbon dioxide fizzing off? This is clever. And then the carbon dioxide enters that cell and becomes a salt again, so that it can be exported. Salt to gas, gas to salt. This is an organ that makes gas. The kidney makes gas. and it makes it in order to reabsorb bicarbonate. Everything angiotensin II controlled. Here's a famous molecule, the sodium glucose transporter that we just commented upon. You know something? You can only have up to 280 milligrams of glucose per DL, per 100 cc's, beyond which you will spill glucose into the urine. So 280 milligrams per DL is a magical number that you all must know. Think diabetics. Below 280, you can be diabetic below 280, right? You won't see glucose-urea. What you will see is, seems to be normal, high blood tests, but nothing in the urine. If you go above 280, you have exceeded the capacity of these transporters, and what will happen is that you'll see more glucose in the urine. The numbers are shown here. You can actually filter up to 560 grams per day of glucose, my goodness, and have zero lost in the urine. But above that, glucose-urea. And so the dipstick for glucose in your diabetic patients. It's all on the basis of this transporter. There is a therapy, there's a new therapy, unbelievable, where a molecule is given that inhibits the sodium-glucose cotransporter. Glucose-urea, what does it do? And it's a way to lower glucose in patients' bodies who have diabetes. It's a new therapy. I think it sounds crazy, but what do I know? It sounds like you would feed bacteria or something, right? More UTIs. I don't know, but that's a new therapy for hyperglycemia. Okay. So the proximal tubule moves water, moves salt, sodium glucose cotransporter, moves bicarbonate, the sodium proton antiporter, the sodium bicarbonate cotransporter. It also disposes of proteins. So in that 200 liters is a lot of small proteins. Like this one, it gets filtered and taken up by the proximal tubule really well, goes right to lysosomes. This is a fluorescent protein going to lysosomes. These dark squiggles are radioactive insulin, taken up right away and degraded by the proximal tubule. So when you have renal failure, you degrade less insulin. The molecule that takes up all these proteins is known as megalin. It's a gigantic protein here at the apical surface, and when you knock it out, you see a lot of proteins in the urine. Here they are. A lot of proteins in the urine and a knockout. This molecule, no one knows how it works. It recognizes almost every single filtered protein that there is. How is that possible? No one knows how this molecule works. It's a gigantic molecule. It looks like a huge Christmas tree and seems to bind all of the proteins that are filtered. Okay, at the other surface, at the basolateral surface of the proximal tubule, of course, is the sodium-potassium ATPase. Shown basolaterally, it's below the nuclei of the cells. It's how you export sodium. There is a molecule that we used to use. It's occasionally still used. It's called digoxin or digitalis. It's a very famous molecule. It is a blocker of the sodium-potassium ATPase. The reason why you want to do that is that you increase the load of sodium inside cells, because it normally kicks out sodium. And as a result, there's a sodium-calcium antiporter that is activated because you have more sodium inside the cell. So that sodium leaves through the antiporter, brings in more calcium, causes better contraction of the heart. And lastly, the last aspect of the proximal tubule is shown right here. And this is a molecule called the organic anion transporter. What this molecule does is it recognizes a lot of small negatively charged substances. And in exchange for alpha-ketoglutarate, moves them into a proximal tubule cell and secretes them by an unknown mechanism into the lumen of the urine. Why is this important? Doesn't sound important to me. But it turns out it's incredibly important to medications. Because a lot of medications we give are small negatively charged substances. And the OAT, the organic anion transporter, I think there are 12 of them or something, will pick up this molecule and move it into the urine really quickly. One of the molecules that it moves very quickly into the urine is called penicillin. Penicillin. Do you know when penicillin was invented? Anyone? Who invented it? Fleming, right? And in 1942, how much penicillin was available to treat patients? How many patients could be treated with the amount of penicillin that had been isolated from a single rotten cantaloupe that was identified in Illinois? How does this happen? Okay, so the Merck company identified one rotten cantaloupe with penicillin, the fungus that makes penicillin. How much penicillin did they extract? How many patients could be treated at that time? There were 10 patients that were treated. It was so rare that people would collect the urine and repurify the penicillin. All this ended in 1943 when a hero, her name is Margaret Trousseau, joined the Merck company in New Jersey and figured out a way to ferment the penicillin, creating 600 billion units of penicillin in a space of 2 years. This had a major impact on the history of warfare, by the way. This is huge, a huge event that about 20% of soldiers could now be saved after an injury. Some people figured, well, okay, so we can make billions of units of penicillin, but maybe we should block the anion transporter. And a molecule called probenecid was discovered that blocks the transporter. If you were active in medicine in probably the 1950s, 60s, 1990s, you were probably giving penicillin and probenecid to certain patients when you wanted to raise the level of penicillin in their body. It was a treatment for syphilis, actually, penicillin probenecid. It was a little before my time, but when I just was entering the system. Probenecid came back into use when AZT was first synthesized, when the AIDS epidemic hit here. Because AZT is a compound that is also directly secreted by the oat, and so we wanted to block it to raise the AZT level in the blood. It didn't work at all for the patient, but that was the concept. You can also see that other medications are secreted by oat into the urine. This is sort of a forgotten aspect of what the proximal tubule does, but it's obviously critical to medication dosages, one of which are diuretics that have to go through the system to reach their target in the nephron. And obviously, if we use probenecid, we would block that. I have to say that this system is very, very complicated. I think it's reversible because, you know something, probenecid blocks uric acid reabsorption and therefore more uric acid in the urine. So I have a feeling that some of these oats are reversible. And probenecid is used in gout therapy. There's a current usage of it. Okay, so the proximal tubule reabsorbs 67% of our sodium chloride water, almost all bicarbonate, glucose, amino acids, through paracellular pathways. It does a good job, but you know something? What comes out and what's left behind looks exactly the same. The sodium to water ratio, the content of things, is, the osmolarity of the urine is not really changed, the thing that remains, because essentially that's a leaky tight junction. So you reabsorb in bulk, but you don't fine-tune it. High capacity, low sensitivity. And last, let's not forget that this is the way we throw away. You take all these expensive medicines, guess where they go? They go right into the urine through the oat system. Angiotensin II and ANF is our major controllers of the glomerular filtration. Angiotensin II is our major controller of the proximal tubule, whereupon we go from 200 liters down to 60 liters of remaining fluid. From 28,000 milliequivalents of sodium chloride, we end up at 8,400 milliequivalents of sodium chloride remaining. We have no glucose amino acids left over. We're still at the same osmolarity we began with. We have a long way to go to make urine. The next stop in the process is the thick ascending limb, which reabsorbs 25% of the remaining sodium. The distal convoluted tubule, 5%. And then the collecting ducts down to 3% of the remaining sodium that's present. Let's go for it. Thick limb. Thick limb, the machinery for reabsorbing sodium, chloride, and potassium. But it doesn't reabsorb water. It's going to pull salt out of the filtrate, but leave the water. Hence, luminal osmolarity will fall. But as it pulls salt out without water, where does the salt go? You have to put it somewhere. and it goes around the tubule and increases the osmolarity around the tubule in the interstitium, creating a very high concentration of junk right outside the thick limb in the interstitium. Sodium, chloride, and also urea transport. It's kind of a weird idea. What we're doing is we're making the filtrate very hypotonic, but we're making the interstitium very hypertonic. And that's what the thick limb does, Lupa-Henle. And here's some of its favorite actors. We have the sodium, potassium, chloride co-transporter, the triple co-transporter. You will love the triple co-transporter. Look, it's electroneutral. 1, 2, 1, 2. Right there. But look what comes right back out. There's a ROM-K. This is a potassium channel. So potassium actually recycles. To drive sodium chloride requires potassium recycling. What a strange system right here. Look at this. It creates a positive charge on the membrane. The positive charge on the membrane has a secondary effect. It is thought to drive sodium, magnesium, and ammonia reabsorption right into the interstitium. As I said, this is a system that would draw salt but not water. So we go through the cell, sodium, potassium, 2 chlorides into the cell. We recycle potassium for keeping this going, but we create a positive charge on the membrane that drives other things paracellularly to the other side, to the basolateral side. So the interstitium is now filling with this material as we're withdrawing it from the urinary space. Water, forget it. It doesn't go in. Water has a reflection coefficient of 1. It's one of the few places in the body that this is even possible. Water permeates every membrane because of aquaporin channels. There are no aquaporin channels here. Water doesn't permeate. Salts are withdrawn. You will, as I say, you will love this molecule. And the reason you'll love it is that you will poison it routinely in all of your patients when they have heart failure and things like that, right? You've already been told about Lasix. Like, this hospital should be renamed the Lasix Hospital, the Milstein Lasix. Every patient is on Lasix, it seems. It's like everyone has too much salt water in their body. Dietary therapy, I don't want to sound like a TV guy, but dietary therapy is extremely important. You just lower the sodium chloride water in the diet. You don't want to eat this stuff. No. So we give Lasix. As a patient is eating pepperoni pizza, we give Lasix, and the pepperoni pizza salt goes right into the urine. Why does it go into? Because we block this guy right here. We also block calcium uptake. If you want to put more calcium into someone's urine, just give them a shot of Lasix as well. Because you inhibit the production of this positive charge on the surface. Bartter syndrome results from mutations in any of these molecules, can contribute to what looks like Bartter syndrome, or in this channel right here. And the syndrome that looks like Bartter syndrome looks like the patient just had a shot of Lasix. You'll hear more about that in subsequent lectures. The distal convoluted tubule has a different machinery. It's a sodium chloride cotransporter. And the sodium chloride cotransporter is a much simpler system, it seems. There's a defect called Gittleman's. It's a defect in the trafficking of this molecule to the cell surface here. This is at the cell surface. It's sensitive to diuretics called thiazides. Thiazide diuretics inhibit the sodium chloride cotransporter. Put more salt in the urine, less going into the cell, back into the blood. The distal convoluted tubule is very different than the thick limb. I just want to comment on that for 1 minute. The thick limb, as it removes salt and chloride and calcium, magnesium, and ammonia and urea, end up deep in the interstitium. The thick limb is coming from the medulla all the way up to the cortex. So it's moving solutes right into the medulla to create medullary hypertonicity. You get it? The distal convoluted tubule, however, is high up in the cortex. And so when it reabsorbs sodium chloride, it goes back into the blood. Pretty straightforward. It doesn't accumulate in the interstitium. The thick limb has a dual role of reabsorbing those solutes and making medullary hypertonicity. So by the time we leave the distal convoluted tubule, we're down to 20 liters of fluid. Remember the initial chart I showed you? That the big red thing that those crazy parents with the kid and all this stuff and the fraternities, right? Up to 20 liters, right? There it is. 20 liters. It wasn't an arbitrary number. 20 liters is what remains at the collecting duct. You see, the collecting duct is this is all very smart stuff, I agree. It's really interesting. It's the collecting duct that has the most brains in the system. So there's 20 liters left over. There's 200 milliequivalents of sodium chloride. It's beginning to sound like dietary stuff, huh? We're getting down to like, Earth-size level things. It's only a trace of bicarbonate. And because I reabsorbed so much salt in the system, the osmolarity has fallen. I've left the water behind. Remember that this is impermeant to water. I've left the water behind, and I mostly have a lot of dilute fluid, therefore. I've left the water behind, taken salt out. I'm down to 100 milliosms per liter at this point. So we're down to something that kind of sounds dietary. And the concept here is that the collecting duct will make the final decisions to try to keep you in balance. And it does so under the influence of two hormones, antidiuretic hormone and aldosterone. So what does the collecting duct do? It reabsorbs the final sodium, secretes potassium to keep us in balance, reabsorbs the final water, and also it adds protons to the urine to acidify. Okay, here's the collecting duct. You'll notice something about it. It's very different than every other segment of the nephron. You know why? Because it has at least 2 cell types, maybe 3 cell types, maybe there are 4 cell types. One of the cell types is called principal cells, and the other is called intercalated cells, shown here. There are many flavors of intercalated cells, and you fortunately will get a lecture from Professor Alicante, who discovered these cells and how that they work in a later lecture. By the way, some of them pump acid in this direction, and some of them pump acid in that direction. Bicarbonate. So here's our principal cell. Here is the main cell of the collecting duct. It has a sodium channel, which is called ENaC. It's sensitive to another diuretic. It has a potassium channel to throw away potassium. This is the segment that is very tightly sealed, one epithelial cell against another epithelial cell. And consequently, it really can create very large gradients of sodium between the lumen and the blood. It's under the influence of aldosterone. So you produce more and more of these channels under the influence of the hormone aldosterone. Aldosterone binds to a mineralocorticoid receptor, and this increases the number and open probability of these channels. Add aldosterone, you will reabsorb more sodium from that final urine and secrete more potassium into the final urine. Here's the intercalated cell. It's entirely different. It has a swarm of these little vesicles that have proton pumps. Under the influence of aldosterone again, pretty interesting, huh? Same hormone. Under the influence of aldosterone, these proton pumps will be inserted into this apical membrane. There's an opposing cell, I said, that goes in the other direction. When a proton pump is put in the apical membrane, it hydrolyzes ATP and pumps acid. Acid combines with stuff in the urine. The major stuff is called ammonia. Ammonia becomes ammonium and takes away that proton and dumps it into the Hudson River downstream. When you move a proton out of a cell, you create a hydroxyl group. The hydroxyl group combines with carbon dioxide under the catalytic activity of carbonic anhydrase and makes a bicarbonate molecule. This system is actually generating new bicarbonate molecules under the influence of aldosterone. It throws away acid and makes a new bicarbonate. These junctions between this cell and its neighboring cells are so tight that you can actually create a proton gradient across them. The urine pH is now falling from 6.2, which is what it was when you took all the bicarbonate out by the time you finished the thiclin. It's now falling down to even to 4.5. So you're acidifying your urine by 3 log orders compared to the blood. How do you have such a big gradient of protons, little molecule like protons? The cells are very tightly sealed. These are tight, tight junctions, allowing this chemical imbalance to be created. This is how meat eaters throw away acid every day. You vegetarians, on the other hand, you make an excess of bicarbonate. And if you think about that, you may want to throw away bicarbonate in your urine. So look at the cell and imagine it working backwards. And so you have some intercalated cells in the cortical segments of the collecting duct high up that work in the opposite direction. And vegetarians will throw away bicarbonate and acidify the blood in response. It's crazy, right? But they do the opposite because they have a base excess from vegetables. Whereas meat eaters, acid into the urine, bicarbonate, thank goodness, back into the blood because we had fizzed it off from all that meat eating. And finally, the last function of this collecting duct, which is mostly in the principal cell, which is all in the principal cells, yes, it's all in the principal cells, are 3 aquaporin channels. Aquaporin 2 is in these little vesicles that in the presence of another hormone, antidiuretic hormone, we've only talked about 4 hormones, norepinephrine, ANF, angiotensin 2, aldosterone, and finally, antidiuretic hormone. Nephrology is powered by 5 hormones. That's it. That's the end of the story, 5 hormones. Antidiuretic hormone causes the fusion of these little vesicles to the apical surface. Those vesicles contain aquaporin 2 channels. At the basolateral surface is aquaporin 3 and 4, always there. But they don't work unless you put aquaporin 2 on the apical side. Remember what's in the duct coming down. Remember the thick limb had removed all the salt, most of the salt, down to only 200 milliequivalents. The remaining stuff is very hypotonic. So you have this watery urine coming down here on the apical surface of these principal cells. And if you put a aquaporin 2 channel in here, water will flux from the lumen through the cell into the interstitium. Why does it go into the interstitium? What's the gradient? The urine is very dilute. What's the concentration of the interstitium? Hyperosmotic. How did the interstitium become hyperosmotic? And what? The thick ascending limb had taken all the salt out and put it in the interstitium. You know what? So by the time you get to the collecting duct, those aquaporin 2 channels can conduct water from the lumen back into the interstitium, which the neighboring thick limb had empowered with all that hyperosmolarity. Do you follow that? Take the salt out, put it there. It's not garbage. It's used for a purpose. And the purpose is to draw water out of the collecting duct back into the interstitium eventually for reabsorption. So it's the antidiuretic hormone that has the final key to the system. You need the thick limb to do its job, but the final key, the acute effect, the thing that changes moment to moment when you need it, is antidiuretic hormone that puts aquaporin 2 channels in the apical membrane and allows for this flux of water. Here is a slide that you saw many months ago. No antidiuretic hormone, antidiuretic hormone. Aquaporin 2 appears at the cell surface. And so here we are, 200 liters, 20 liters by the collecting duct, down to 0.5 to 1 to 2 liters, with sodium having been removed by ENaC in the principal cells, water having been removed by aquaporin 2 in the principal cells, the urine acidifying because of the intercalated cells, or alkalinizing because of other intercalated cells moving bicarbonate. And water have been drawn, and you have a hyperosmotic urine that you eventually will throw away. Here are the functions of the different segments of the nephron. Isotonic reabsorption, generation of medullary hypertonicity and reabsorption of salt without water, finally, reabsorption of the final sodium in water and secretion of protons and bicarbonate. That which is thrown away is the excess of which you ate in the past 24 to 48 hours. And down we go to the bladder and into the Hudson River we go. What's the point of all this? The point of all this is that our environment could be changing, our intakes could be changing, our body temperature could change. We may have an infection, our non-renal output could change. What the kidney does is filter all of that stuff and does all of these long processes in order to create that final urine, with an attempt that the amount that it throws away is to drive this equation down to 0. And the reason for all that is very simple. So you are the same person you were yesterday because of the kidney, because ever the junk you ate has been removed very specifically, and all the rest of your body constituents has been reabsorbed. If you don't become all nephrologists now, I have failed my job. I'll see you Monday. dehydrated, your body's osmolarity increases, more antidiuretic hormone is made. Goes and puts more aquaporin C channels there.
So then what is excreted from the body?
Very, very concentrated urine. You know that from personal experience. When you wake up in the morning and you haven't been drinking all night, the urine is always darker. The reason is you withdraw more water, more aquaporin C channels. Why? Because more antidiuretic hormone. Why do you need more? Because your body's osmolarity rises, triggering the release of ADH from the brain.
Why doesn't the body keep all the water? Like
You can't go to zero because remember, you'd be in renal failure below 400 cc's. And the reason is that the reabsorb drunk, you won't be able to. The beauty of the system is you still have the same GFR, so you just remove all the water. You know, birds, your pee, it's like poop, right? It's thick, right? There's very little water in it. They can go up to like 17,000, I mean, they do solid urine. So you're still getting rid of the fat, but you're keeping the water. That's what you do. When you wake up in the morning, that's what you're doing. You're reabsorbing water from the kidney. Yeah, it's really interesting.
I had a question about
Bicarbonates. Let's ask them. They make more bicarbonates.
They think that that's the reason why they change
I can't comment. I think there's a lot of substances in meat. The meat is metabolized and creates a lot of stuff. And some of these are linked to things like atherosclerosis and things. And cholesterol. I don't know the answer.
Wait,
What's that?
doesn't matter how much salt you
Okay. So we're going to do this more on Monday. What happens is that, let's say your diet is like this with whatever substance, okay? There's celery go like this, right? Okay. The kidney, over a space of 2 days, will catch up and balance you in your diet. So if your diet goes up and stays the same, your kidney will come up and match it. So what's the problem? Well, your body weight just increased by a couple of liters or whatever it is, or something, right? So you increase your body weight, but the kidney will catch up to that new point. It doesn't remove it back to your original 12-year-old set point. It just keeps up with what the environment is handing it. See the difference? So in the meantime, the patient has gotten fatter.
Does he have high levels of salt? Is it a steady state of higher levels of salt?
If you eat a lot of the high levels of salt every single day, the kidney will catch up, so you will be at a new set point of more salt in your body. If it's a spike, go out and have a nice salty dinner, all delicious. Yeah, if you go back to your regular diet, the kidney will do that and then come right back down. So it's just balancing what the environment is throwing out.
Okay, that makes sense.
Yeah, yeah.
Dr. Rush, just a quick question. The slide where you talked about creatinine.
Oh,
Actually, I could get that
first lecture or second? Where?
for a second. Here, also is the fact that once you lose that first kidney, volume also goes down.
Well, okay. So remember the volume of the urine?
Yeah.
Aquaporin 2, antidiuretic hormone,
Okay.
independent of filtration.
Okay.
It's a post-filtration manipulation.
Okay. But it's even on a far more primordial level, just the fact that you only have one kidney churning it out.
Yep, twice the amount.
All right. So basically, it's still just a matter of clearing the blood.
Clearing the blood at twice the amount.
Okay.
Just because the blood has a higher concentration of stuff in it.
Okay.
So the urine volume is regulated very separately.
Okay. And then also, just you brought up the notion of amputation, they'll have less creatinine.
That's right.
But they'll also have less blood to actually clear out. Because you wouldn't need to supply that part of the body, so over time you probably have lower blood levels, but you probably still have the same percentage being cleared. Or probably not.
That's a new wrinkle. If you're missing a leg, sure, there's liter of blood in the leg. Your blood volume could decrease by a liter. and your creatinine certainly would be less than what remains. You're saying that those are proportional changes, and therefore you shouldn't see a decrease in creatinine. Or you shouldn't see a decrease because lower creatinine, lower blood volume. But
You'll see an absolute decrease in creatinine.
No,
of
I
course,
get that, but the concentration
Yeah.
should be the same. Good point. I can tell you from experience, creatinine does go down on amputations. So it must be you're losing more generative for creatinine than you are losing blood volume.
Okay.
That's all I can say.
All right.
I can't comment
But at
further.
the end of the day, in a clinical setting, you're going to measure the absolute value of creatinine.
No, you
per
measure
month.
the concentration.
The concentration.
Yeah, it's milligrams per deciliter. So you measure the concentration, and I promise you the creatinine will decline. And you're right, because you're losing volume at the same time. I never thought of it.
Okay.
I'd have to check it out.
All right.
It'd be nice to look up a series of amputees of their creatinine and actually get the real data. Probably should do that for next year.
Yeah, that.
Yeah.
And then